The theme for this year's EMS week is This is EMS, Caring for Our Communities. This year's theme could not be a more perfect description of what EMS does every day, not just during the last year, but every day of every year, you're out there ready to respond, support, and care for your communities. You may not always get the recognition you deserve, but know that your dedication and passion for what you do makes a difference in the lives of your communities. This last year has been one heck of a ride for many of us, lots of ups and downs. And while no one can predict what the year ahead has in store for us, there is no doubt that EMS, that you will rise to the challenge. Thank you for what you do. Continue to take care of yourself, take care of each other, and happy EMS week from North Memorial Air Care. Welcome to our 2021 first ever virtual Air Care Spring Conference. While we miss seeing you all in person, we are super excited at the amount of you that have joined us virtually. Please use the chat feature like Matt mentioned to share your ideas, to communicate with each other and interact. There's a Q&A function at the bottom of the Zoom. We do have a moderator that'll be checking out those questions. They'll give them to the speaker at the end of their talk, and we can have a little Q&A session. So go grab some food, maybe a cocktail, and let's enjoy the evening. Right. So tonight we're going to talk about the trauma triad of death. Now the triad's had a lot of attention lately, and I think that's really good because what happens is I think in our environment, we very often overlook and underappreciate it. We get so focused on the resuscitation, the airway, and all the cool stuff that it's super easy to forget about the vicious cycle that's happening. So this talk is structured to cover for everybody from the first responding unit on scene all the way through the emergency room. I have no disclosures. I get no kickbacks or financial gains from any companies. And I just want to say, as always, follow your local protocols. So I was inspired to do this talk by a very similar talk I attended at AMTC a couple of years ago. The speaker of that talk was from Louisiana. And as he was talking, he was telling us how they were noticing that all of their trauma patients were hypothermic. And he kind of went through the vicious cycle. And I sat there and I just kept thinking to myself, if they're cold in Louisiana, they've got to be freezing in Minnesota. It's a lot colder here than it is there. And while our patients aren't freezing, they are hypothermic. So I knew before that talk was even done, I had to bring this talk back here. So since then, I've given this a few different talks, a few different conferences, and most recently do a paramedic class where I hope will inspire their habits early on. So after a lot of research and a lot of personal observations, I feel very passionately about preventing hypothermia in our trauma patients. And hopefully we can stop the lethal trauma triad of setting in. I think the roles that we play in EMS and the emergency rooms can impact our trauma survival, and we can stop the triad from setting in. I know shock care is a learning station we all kind of go through, and we say, keep your patient warm to pass the testing station. But do we ever really learn why? Do we know why it's so important to keep our patients warm? Why is it so important to prevent their heat loss? So throughout this talk, I hope that you develop a better understanding and some respect for the trauma triad of death. And I hope that you utilize what you learned here today to improve the survival of your trauma patient. So this is our patient. It's 11 p.m. on a Friday night. You get called to a gunshot victim. Scene is safe. You have your BSI. And you notice that he's got an arterial leg wound. He's got an abdominal wound and some chest wounds. You can see his vital signs right there. And your trauma center is 20 minutes away by ground. So as you think about this patient, it's easy to go, okay, yep, we need to stop the bleeding. We need to expose. We need to get him in the back of our truck and get him to a trauma center. But I want you to keep this patient in your mind as we walk through this talk today. So what exactly are we going to talk about? Well, we're going to discuss the trauma triad of death and the components that cycle off of each other and how it kind of feeds itself. We're going to really focus on hypothermia. That's going to be the main part of this because that's the area we have the most impact on. We're going to talk a little bit about acidosis, a little bit about coagulopathies, and then we're going to discuss interventions that we can do pre-hospitally to improve our patients' mortality. It's time that we start thinking about 30-day mortality and not just the 20 to 30 minutes that we're with them. So some key terms to know as you're going through this: acidosis, it's a lower than normal pH. Body doesn't like to have acid buildup in it. The coagulation system is the body's normal system to form clots. Coagulopathy is any clotting or bleeding disorder or inability to form clots. Hypothermia is a lower than normal body temperature. And the lethal triad is the combination of acidosis, hypothermia, and coagulopathy that usually leads to death in a patient experiencing trauma. So what is the trauma triad of death? Well, it's a self-sustaining cycle of acidosis, hypothermia, and coagulopathy. It becomes established very quickly after the initial onset of the injury. A 1982 study described it as the bloody vicious cycle. And ultimately, if it's left untreated, it will result in continued hemorrhage and eventually death of your trauma patient. To successfully resuscitate a critically ill trauma patient, emergency providers need to have an understanding of the triad and interventions that they do to make it worse or to eventually prevent it. Hemorrhage in trauma patients causes hypothermia, acidosis, and coagulopathy. Hypothermia worsens acidosis, acidosis and hypothermia worsen coagulopathy, and coagulopathy causes more bleeding, and the cycle just continues, and it starts to just feed itself, and once it sets in, it's hard to get that stopgap into it. So while we in EMS may not see the immediate effects of the trauma triad of death, it does lead to death within weeks after the initial injury if left untreated. Again, it's time that we start thinking about 28 to 30-day mortality rates and not just the little bit that we are with them. It does us no good to give ourselves a big pat on the back because we saved our patient, AKA we made the numbers look really pretty, if what we did contributed to this ultimate vicious cycle. So we're going to start with hypothermia, and this is where we're going to spend most of our time tonight. So hypothermia is defined as a lower than normal body temperature. So less than 35 degrees Celsius is the typical definition of hypothermia. However, in trauma, that actually shifts a little bit. And even mild hypothermia is 36 degrees Celsius. And so if you're not familiar with Celsius, 37 is normal. 37 to 38 is what would be normal. So when we start to kind of shift to the left of that, that'll kind of give you some guidance as far as what that looks like. So one study actually found that almost half of all EMS transported trauma patients had a temperature of less than 36 degrees. What's even more fascinating is that was regardless of the time of year. So even in the summertime, 50% of our trauma patients are showing up in the emergency room hypothermic. So there have been studies out of Iraq, as a matter of fact, that I thought were kind of fascinating, and they have shown that patients injured in the battlefield arriving in the MASH units are hypothermic, simply from the mechanism of injury. If you think of the temperatures there and the temperatures here, we clearly need to be treating this. In a study of 71 trauma patients, a core temperature of less than 32 degrees was associated with a 100% mortality rate, independent of the presence of shock, injury severity, and volume of fluid resuscitation. Even mild hypothermia in a trauma patient can have devastating physiological consequences. The clotting cascade, the thing that keeps us from continuing to bleed, is temperature dependent. So once a patient's core temperature drops, their ability to clot goes away. And the sad part is, what we do, thinking that we're helping, can often be one of the biggest contributors. So we give normal saline, right? Lots of normal saline, that's our friend. But what is it kept at? What temperature do you think room temperature is? It's 20 to 25 degrees Celsius is room temperature if you were to take that. So again, we talked about 37 to 38 is what's normal body temperature, and we put 20 degrees Celsius normal saline into them. And that's not even in the wintertime. So how many of your ambulances have warmed cabinets for your saline? Do you have the means to warm them? Not a lot of people do. And so what we're doing is we're basically giving ice water to our already hypothermic susceptible patient. What's even more fascinating is blood products. If you have the ability to carry those are stored at 3 to 10 degrees Celsius. So think about that in your trauma patient. Yes, we're giving them blood, but if we're making them that cold, if we're not actively warming our blood, what's the balance that we're doing here? In Operation Iraqi Freedom, tactical combat casualty care was kind of a new concept, and they followed PHTLS, which was 2 liters of normal saline, regardless, and then transported. And it wasn't until they changed their care and they changed their treatment to fluids only when hemodynamically unstable, and they put an emphasis on hypothermia, did military casualty fatality rate actually decrease. So we often think of hypothermia as the guy who wanders off in the middle of winter. We find him in the snowbank. He's blue, he's ice cold. And while, yes, that is hypothermia, that's not the kind of hypothermia we're talking about today. So here are some common myths associated with hypothermia and trauma. Number 1, environment is the most significant contributing factor. That's just not true. In fact, in trauma patients, the most common is blood loss. Simply the act of hemorrhage causes our body to become hypothermic. So while the guy that wanders off into the snowbank passes out and we find him in the morning, while he is hypothermic, he's not hypothermic from trauma. He literally is just hypothermic from being outside. So the body doesn't have a heat pump, right? Our heat pump is our metabolism. We've all heard that before, right? The faster our metabolism, the hotter we tend to be. But what happens is when we lose our blood volume, we lose our metabolism and it starts to slow down, and we lose our oxygen carrying capacity. So as our metabolism slows down, our ability to warm ourselves also becomes compromised. This is going to occur regardless of environmental exposure. So again, in the middle of summer, if you have a trauma patient who has any kind of hemorrhage, they're going to be hypothermic simply from the act of bleeding. The first step in preventing hypothermia is March. And in fact, if you haven't heard of the March mnemonic for trauma, it talks about massive bleeding. We always stop the bleeding, airway, respiration, circulation, and hypothermia. Hypothermia is so important in our trauma care, it gets its own letter in the trauma mnemonic. Myth number 2, hypothermia is not uncommon, or is uncommon and is not lethal. Well, we've already established that in the short time that we've been together, that that's just not true. 66% of trauma patients become hypothermic, and all trauma patients will experience a drop in core temperature. More than a third of critically ill trauma patients admitted to the ICU were hypothermic upon arrival at the ICU. And it's easy to see why, right? These are very sick patients, and we have lots of things on our mind and lots of things to think about. Somebody's on the team. Their thought has to be about keeping that patient warm. Myth number 3, a blanket is the best treatment for hypothermia. Now, I'm not saying don't put a blanket on your patient. I'm just saying perhaps the one little blanket in the back of your ambulance is not going to warm up your hypothermic patient. We have to be mindful and we have to be intentional about how we keep our trauma patients warm. It's going to take a really long time to raise your core temperature of your trauma patient by simply putting a blanket over them. And then myth number 4 is probably my favorite one because it encompasses some of our thoughts in EMS, right? Hypothermia is not my problem, right? I got them from the scene and I dropped them off at the hospital and they were alive. I did awesome. So, but that's just not the case, right? We have to look at our patient as a whole, as their whole patient care continuum, because the things that we do pre-hospitally or don't do pre-hospitally, they have a really big impact on our patient and our patient mortality. So by simply keeping your patients warm, you can have a huge impact on their survival. So if we can keep them warm, hopefully we prevent the clotting cascade from failing, acidosis from setting in, because once the trauma triad sets in, it's almost too late. So an ounce of prevention is worth a pound of cure, right? It's such a perfect quote for this talk right now, because an ounce of prevention, if we just do a couple of things to keep our patient from becoming hypothermic, we can make a huge impact on the patient. So what are we going to do, right? Well, number 1, we're going to stop the bleed, right? I am not trying to replace M in the trauma mnemonic. We are always going to stop the bleed. We do not want anybody to bleed out. So this is going to come first before anything else. And don't stop at the first source. Always look for more sources, right? We have to assume our patient is bleeding from multiple sites. And then step number 2 is keep your patient warm. We have to stop trauma naked, right? What's the first thing we're taught in school in trauma care? Strip and flip, right? Get them naked, look for injuries, look for any life threats. Was great. I'm not saying don't do that. I'm saying cover them back up after you're done doing that. I have been there. We get so focused. We do this really quick head to toe assessment. We look for all the injuries. We don't find anything. And then there lays our patient, naked on a backboard, or very little dressed on a backboard, right? It's easy to do. Your rapid trauma assessment really should not take more than a few minutes. So get that quick head to toe assessment done and then cover your patient back up. Where's your backboard kept? I'm gonna guess it's in an outside compartment. Is your outside compartment heated? If it is, you have a really fancy ambulance, because I've never seen a backboard that was heated in the outside of an ambulance. So if you do, that's amazing. I'm gonna guess you don't though. So you take this ice cold, hard plastic backboard out of the back of your truck, and you go to this massive trauma patient in the ditch in the middle of winter, and you put them onto this ice box. What do we think is going to happen? It's just going to contribute to that hypothermia. I'm not going to get into the debate on whether we put patients on backboards or not. That's a whole other talk. But what I am going to say is that if you're going to put them on a backboard, maybe put a blanket between them and the backboard. Or better yet, use the backboard as extrication, get them off the backboard as soon as possible. Not only does a backboard contribute to hypothermia, it can cause bed sores, it can cause injuries, and it's very uncomfortable. So now this is always my favorite one. And if there were people in the room for me to see it, I always see the gasps. You need to turn the heat up in your ambulance, like high, so that it's hot and it's sweaty, because guess what? This isn't your emergency. This is the patient's emergency. They're the one that's at risk of hypothermia. Now I get it. I do not like to be hot and sweaty and sweat running in my eyes, and you've got all of the PPE and it's a huge pain in the butt. I get it. I totally understand. But we have to be thinking about our patients, right? We have to be thinking about what environment are we putting them in. Have you walked into a trauma room and it was like 90 degrees when you walked in? That's good. That's what we want it to be. We should always walk into a trauma room and have it be 90 degrees and have it feel hot, because that's what's good for our patients. Not good for us, good for our patients. So if you have the ability to warm blankets, that's even better. So I know some ambulances have warming cabinets. They can put a few blankets inside. Emergency rooms have those really nice blanket warmers. They do make commercially available warming blankets that you plug in and they warm up. Any of those things are going to help keep your patient warmer. So if you have the ability and the availability of getting those warm blankets, make sure that you use them. And if you are covering your patient up, make sure you're actually covering them up. I know that I've seen it. I'm pretty sure we've all done it. We haphazardly throw that really nice wool blanket over our patients, right? We're like, yeah, we got our wool blanket. We're keeping our patient warm, just like the checklist tells us to. We kind of throw it over our patient. It's kitty wampus. Maybe it's covering part of their chest. Maybe it's across their pelvis, across their private parts, but we're really not covering our patient up, and we're really not warming them all that great. So somebody on the team be intentional about keeping that patient covered up. And finally, if you have the ability, you really should be administering warmed IV fluids. So this goes with your blood products and normal saline and LR, whatever it is that you're using. We really should be warming those. So if you've got a warming cabinet, a warming bag, a device, that kind of thing, in the emergency rooms, I know that they tend to keep their fluids in like a heater compartment, any of those kinds of things. Make sure that you're warming it, because remember, blood is 2 to 10 degrees, putting that into our already hypothermic trauma patient. Think about what that's going to do. We want to typically warm it to 40 to 42 degrees is kind of what our goal is. So that's my spiel on hypothermia. So let's talk about acidosis. So acidosis is a lower than normal acid in the body, right? We established that in the So acidosis in trauma is most often caused by poor tissue perfusion. So anemia from acute blood loss, so they have bled out, peripheral vasoconstriction in response to hypothermia and blood loss, or body kind of clamps down because it's cold, it's trying to conserve, and then just an overall decreased cardiac output from our trauma patient can all severely impair oxygen delivery to the tissue. So when our oxygen demand is greater, so our trauma patient is stressed, they've just experienced a massive trauma, they're bleeding out, their oxygen demand is going to be up, but the problem is they don't have oxygen carrying capability. And what happens is this leads to anaerobic metabolism, which means they're not using oxygen to try to warm the body. And what happens then is we build up lactic acid. As we build up lactic acid, we're going to increase our acidosis. So this process is going to occur in the presence of normal or even slightly abnormal vital signs. So your patient will start to become acidotic long before you ever realize they could potentially be acidotic. A really nice tool that actually we can use to kind of monitor tissue perfusion in the pre-hospital environment is nasal cannula and tidal CO2. So that will help give you an insight into their metabolic state. If your end tidal CO2 is really low, you probably have poor tissue perfusion. So, and this low end tidal is going to show long before any of your other vital signs change. It's almost instantaneous. So fluid resuscitation in the trauma patient has been an ongoing challenge, right? It's reviewed, it's debated, it goes back and forth between LR, nope, normal saline is better, nope, whole blood is better, nope, no, we really should be doing normal saline. Like you can't really keep up on it all, right? But the type of fluid you give is going to be dependent on what you have. And that's just the reality. If we all had a perfect world, everybody would be carrying whole blood and they'd be warming it, and that would be awesome. But that's not the world we live in. So you're going to give whatever it is you have available to give, whether that be LR, whether that be normal saline, or if you're lucky enough to carry blood. That's pretty awesome. So when administering this fluid, we want to administer just enough to create a map of 65. So 65 is what they say will perfuse your brain. It's basically an improved tissue perfusion. A systolic of 90, that's a pretty common one that we hear, right? We want the systolic of 90. And so we're going to try to limit the amount of normal saline that we give these patients. So the pH of normal saline is like, it's on my next slide. We'll wait till we get there. So while the couple of liters that we give pre-hospitally, again, in our little bubble of the patient care continuum, we might give 1 to 2 liters of normal saline. Probably not a huge impact, maybe a little bit, it's still pretty acidotic. But then let's talk about the another 1 to 2 that get in the emergency room. And then we all know how much the OR gives you. So this just compiles and it just adds up over time. So we want to make sure that we limit the amount of crystalloid to just enough to improve tissue perfusion. So they say to maybe give 250 boluses, 500 boluses, give them those little bits at a time and see if that's all they need. If they only needed 250, then awesome, we don't have to continue to give them this. So in fact, one study has actually shown that if you give 250 mils rapidly over 30 seconds, whether it be through a syringe flush, they make this like gun device kind of that gives fluid boluses really fast. If you administer that 250 mils over 30 seconds, it will increase your radial pulse, it will increase your MAP, and it will improve your SpO2 waveform compared to that same 250 mils over 10 minutes. So this might be a way for us to accomplish getting the tissue perfusion that we want with less fluids. And finally, don't forget that we can have a patient who's in respiratory acidosis. This can be a result of hypoventilation due to respiratory depression, obstruction, anything that kind of keeps them from releasing or increased CO2 levels. This could be caused by narcotic, alcohol use, traumatic brain injury, flail chest, other pre-existing type conditions. So what should we do? Again, how do we prevent acidosis from starting? And again, if you were all in the room, you would all say, stop the bleeding, right? Because that's first and foremost. The moment we stop the bleeding, we stop the entire cascade from kicking in. So it can have cardiovascular, pulmonary, neurological, and bleeding effects. So we need to stop the bleeding early. Keep your patient warm. right? If your patient starts to shiver, they build up lactic acid. So keep your patient warm, keep them from shivering, make sure they don't get there. Administer oxygen. That's an easy one. We all like our oxygen. And then limit the amount of crystalloid. Your patient needs just enough to get to a MAP of 65. So here's our pH. The pH of normal saline is 5.5. Normal pH, so us right here, you sitting at home, yours is 7.35 to 7.45. That's a normal range. The lower the number, the more acidotic it is. So if you're giving something with a pH of 5.5, you're literally giving them acid in their body. Be mindful of it. Keep it on the lower end. Give just enough to get good tissue perfusion. And then if you have the ability, give blood products early and warm them up. Okay, coagulopathy. So just stay with me. We're not going to dig into this super lot. So coagulopathy can occur for a number of reasons. However, regardless of the cause, coagulopathy results in the potential for continued hemorrhage in the bleeding trauma patient. So I'm not going to get into the whole detail of the clotting cascade because that's more than we really want to get into tonight, trust me. But ultimately, coagulopathy is a bleeding disorder with massive hemorrhage. So your patient is bleeding out. They lose their ability to clot. They bleed out their clotting factor. And so tissue trauma and shock state abnormally activate the clotting cascade. So they were injured. They bled out a whole bunch. The body tried to make clots to stop it. And then for some reason, the body gets confused and goes, we don't want clots. No. Clots are bad. They're a foreign body. And then it tries to break down the clots that are formed in there. So making this harder for the clots that are there to stay. So this whole diagram that's on the sheet is really a fancy way of showing that all severe trauma ends in coagulopathy without the correct interventions. So you have major trauma, your patient starts bleeding, they get tissue hypoxia, acidosis, coagulopathy. Or you have bleeding, and you give all kinds of crystalloid solution. You dilute out what clotting factors they had left, they continue to bleed. Or they bleed out, you give all this crystalloid solution, they get hypothermic, and they continue to bleed out. You kind of get the idea. So we don't really have any way to test for coagulopathies in the field, so we have to maintain a high index of suspicion based on the mechanism of injury. And we have to understand that these other things, the hypothermia that we spent so much time talking about, if we don't fix that, it's going to result in continued bleeding. Obviously, patients on blood thinners have an increased risk of coagulopathies just by the nature of medicine, and they ultimately will lead to DIC. So remember, hypothermia and acidosis both contribute to coagulopathy as well as continued bleeding. So we kind of talked about what happens when our patient has bled out, they've lost a couple liters maybe, and we put in normal saline. So we take what blood they had circulating around and now we dilute it out. So maybe the clotting factors that they had are now diluted out and they can't do what they're supposed to do. So it's called dilutional coagulopathy. And it occurs when we, as providers, think that we're doing the right thing, right? This is what we were taught. We were taught to give 2 liters of normal saline. So we're doing what we were taught to do, but in turn, is it making our patient better or is it making our patient worse? We just need to be mindful about that. Packed red blood cells and other blood products should be administered using a blood warmer. Make sure that we're getting those early. Your initial rate of transfusion, really your goal should be to restore tissue perfusion. We can definitely allow permissive hypotension. Again, remember this is something that, do we really want to get their blood pressures up to 110? Probably not if they're internally bleeding, because if the body has started to build a clot, we increase their pressures too much, there's a chance we could break that clot back off, right? So make sure that just enough to get tissue perfusion. So again, what do? You're all yelling, stop the bleeding. I could hear it. Administer TXA if you have that available. So TXA is going to help the body not break down the clots that had started to form. So if your body's doing what it's supposed to do and it forms a clot in your belly to stop the bleeding that was there, TXA is going to keep the body from breaking down that clot. down that clot until you can get to surgery. We want to make sure that we maintain patient temperature. That's not new. Limit normal saline administration. So not only is that cold, not only is that acid, but it's also going to cause dilutional coagulopathy. So let's go back to our patient. Again, so we have this patient lying on the road. So you get called as a 911 to a gunshot wound in the city, 20 minutes from a trauma center. Turn the heat on in the back of your truck, right? That's a super easy thing. Flip that switch on. It's already pre-warmed by the time you get on scene. Get on scene, you're gonna do your rapid trauma assessment, do your life-saving measures, stop the bleeding, keep all of those in, make sure that you keep them warm in the back of the truck. So this guy's laying on the concrete, right? Depending on time of year, I think concrete's always fairly cold, unless it's like 110 degrees and it's the middle of the day and you're on a black cement. But get them off the road, right? I always like to say, get them in my office, the back of the helicopter, the back of the ambulance. That's my office, right? It's where I work. Everything's controlled. I can control the temperature. I can control the bystanders. Get them back there in the hot, warm ambulance. Take care of what you need to do. Limit your fluids so that you get better tissue perfusion. Improve your end tidal. This guy's, I was going to give a little dot like you guys could see what I was circling. Your end tidal is 22. That's a really good indicator because his respiratory rate is 28. So he could be blowing off CO2. He could have poor tissue perfusion. So keep an eye, give him some oxygen, and then transport him to the trauma center. If you're farther away than 20 minutes, or maybe this patient needs blood, there's always other resources that you can call for those. So what are our treatment goals? So it begins and ends with bleeding, right? Don't stop at the first source. There's always more sources, right? Assume your patient is bleeding in more places. Always assume your patient is cold because all of the studies show that they are. If there's a prolonged extrication, even in the summertime, cover your patient up with blankets. Not only does it keep the glass from coming all over them, but it also helps to keep them from getting hypothermic. If you're using a backboard, put a towel or blanket underneath it, right? Keep their cold skin off of this cold backboard. Make sure you remove wet and bloody clothing. I feel like that's pretty standard. Replace it with warm blankets. If you have the ability, make sure you're warming your blankets up. Shivering wastes valuable energy and produces more lactic acid, leading to worsening acidosis. Don't let them get cold. We don't bleed normal saline. We bleed blood. So if we can get blood products in early, start the mass transfusion protocol earlier rather than later, our patients have better outcome. Just make sure that you're warming them up. If you are administering normal saline, just make sure you give enough for tissue perfusion, right? We don't want to give so much that we cause the coagulation, dilutional coagulopathy. It's typically defined, so kind of an easy way is if they didn't have a radial pulse and you give them some fluid and they do have a radial pulse now, that's good tissue perfusion. Obviously, monitor and maximize oxygenation. So I think it's important to remember the trauma triad of death is a self-sustaining cycle. Once a patient enters it, it just continues and it starts to feed off of each other. Bleeding causes hypothermia. Hard fact, can't change that. It causes acidosis and it causes coagulopathy. Hypothermia worsens it, acidosis and hypothermia worsen coagulopathy, and coagulopathy worsens the bleeding, and it goes round and round and round and round. So anything that we can do in the pre-hospital environment, the better off we're going to be. What does ITLS say? Right? So these are the most current guidelines. Well, interesting enough, they also say reduce additional heat loss. They also say warm your fluids to 40 to 42 degrees Celsius. Limit use of crystalloids and avoid dilutional coagulopathy. Permissive hypotension. So again, kind of talking about we don't necessarily need them to have a blood pressure of 110. In fact, we're fine with a little bit of hypotension as long as they're perfusing. If you don't have blood products, limit your normal saline to 500 mils at a time. 500 mils and reassess. It's super easy to hang that liter bag, open it wide open, and get distracted with other things and forget to come back to it, right? And so next thing you know, they had that whole liter and now their blood pressure is 110, where maybe they only needed 250 of that to get a decent perfusion. Maybe they needed 500. We want to make sure that we're reassessing those fluid boluses. And then administer fluid until return of palpable pulse, or the patient's mental status improves, or systolic blood pressure of 90. Those are right from the ITLS guidelines. So when we're faced with the unique challenge of resuscitating a critically ill trauma patient in the dynamic pre-hospital environment that we work in, knowledge of and respect of the lethal triad of death is mission critical. Hemorrhage and trauma causes acidosis, hypothermia, and coagulopathy, period. It all ends up cycling and it all ends up leading to continued hemorrhage, to death of your patients. It truly is a self-sustaining cycle once they end up there. EMS, luckily, you are uniquely positioned to combat this silent cycle of death before it spirals out of control. At the end of the day, recognition and prevention of this lethal triad is more effective than any treatment that you're going to do. You are the front lines of our trauma system, right? You're the ones that get to these patients first. You're the ones that put a stop in the bleeding. You're also the ones that can make an impact on those 28 to 30 day mortality rates. What you do in the field to start with can make a lasting impact on the patient. Thank you. And we'll open it up for questions.
Thanks, Billy. Daniel Logan has a question. Thoughts on diamond of death, hypocalcemia?
Were you in my brain last night? I was debating whether to put it in there. So yeah, so the diamond of death is kind of it's the next step of the trauma triad of death. And what happens is when we bleed out, there's a fourth thing that can happen. It's called hypocalcemia. So when we bleed out and when we give blood products, we give other things, they have citrate in them. And the calcium will bind to the citrate, causing hypocalcemia, which reduces cardiac contractility, which reduces our ability to clot, and which also increases our chance of bleeding out. So I debated updating it. It'll be in my next version. That's a really good thought, though. Thank you.
Thank you. Kaylee Fallows has a question. What temperature method is going to be best to monitor a trauma patient's temp?
That is also a good question. So if they're awake, I actually like axillary the best. You can kind of tuck the thermometer if you have like a soft-sided thermometer that plugs into your monitor, and kind of tuck it up into their axillary, because then you can hold their arm down and it's more reliable, doesn't get as much ambient air. If you need to, I mean, a forehead thermometer is probably not going to be super reliable if they have been outside. And then if you have intubated, I would recommend esophageal to monitor that temperature. And it's really more about a trend, right, than necessarily specific. We kind of give those ranges, but if you started temperature monitoring and let's say they were at 36 and then you checked it again and they're at 35, whether that's the true temperature, we know that we're getting colder and we can kind of step in and intervene right there.
Okay, and a question in chat, unknown name, ideas to keep fluids at 104 degrees in the truck.
So there are lots of commercially available devices. So I know some trucks actually have warmer cabinets built into them. So that's always an option. Some make kind of like a bag. It's a warming bag. That's probably the easiest way to do it, is you put some saline inside of a warming bag. It plugs into the wall. It's just an AC adapter and it'll warm the fluids up that way. There are also fluid administration warmers. There's a couple of different ones out on the market that will actually warm the fluid as you administer. So you don't necessarily have to keep it stored at that temperature, but it will actually warm it as you administer it. I know when I used to work on the truck, one of the ways that we would warm our fluid is we would put it in the dash and turn the heat on high. And I don't know if that's probably completely recommended, but it's one way that we used to warm it up. Another way that I used to warm it up when I didn't have any commercially available devices, I would take hot packs and just put it on either side of the IV tubing. And then as the fluid went through it, it would warm it. So there's a couple of different ways that you could look at it. If you're going to get a commercial device, the easiest one would be a plug-in bag that kind of warms the fluid up that way.
Great. So somebody asked maybe a stupid question, and I'll reply, no question is ever stupid, but is warm blood and saline carried on the helicopters?
We warm it. So yes, we carry the blood is stored at 2 to 10 just to keep it at a safe temperature so that we're able to use it. And then as it's administered, we use a fluid warming device that will actually warm the blood or the saline, whatever we're running, to 42 degrees Celsius.
All right. Jared Skeebens has a question. Do you recommend placing hot packs around saline bags to warm them up?
That's the old school way to do it, right? We adapt and overcome. Like I said, I don't know that necessarily that's an approved way to do it, but I can say that I have definitely warmed normal saline using hot packs on the saline bag.
Practical. That's all I have for questions now. If anybody else has any, feel free to type them in. Here we go. Lori Jensen, for basic BLS crews that can't do fluids, best things to do to prevent trauma, triad, would be to keep a patient warm and apply O2, question mark?
Absolutely. Yep. So you get called to a trauma patient, warm up the back of your truck, right? Get that compartment warmed up and ready to receive that patient, much like a trauma bay would do. And then yes, keep them, cover their heads, right? Make sure we don't lose heat through our head, package them up. If your protocol allows, get them off of the backboard early because that's a very cold, hard piece of plastic that's just pulling heat from the body. So get them off of that early if you're able to. And then, yeah, wrap them up with blankets, and trauma patients get oxygen.
Okay. Any
Cool.
other questions? One more just came in.
Okay.
Jared Skeebens, if we're pushing fluids rapidly like the 250 ml you talked about, does this break clots?
It does not. So that lower one, because you're giving it through the peripheral, it's helping to improve vasculature and improve tissue perfusion. If you give those smaller boluses, they shouldn't break up clots that are formed within the belly.
Great, thank you. All right, I think that's it for now. Thank you very much, Billy.
Thank you guys. Enjoy the rest of your night.
Well, good evening, everyone. I'm Paula Fink-Koken, and we're going to be talking about pediatric emergencies. So we're going to dive right into the case. So a 911 call comes in, and you hear the statement, "It's an unresponsive infant." Or you hear, "It's an unresponsive child." Or you hear, "It's an unresponsive teen." Oh my God, an unresponsive infant. What am I going to do? Oh no. This is going to be terrible. It's got to be child abuse. No, it's going to be terrible. Do I remember my CPR for infant? Oh, it's going to be terrible. It's the SIDS, and we aren't going to get anything good. Or for the unresponsive child. Oh no, it's going to be terrible. It's child abuse. No, it's going to be terrible. Do I remember my child CPR? And then, oh my, I've got kids. I wonder if this kid is the same age as my kid. And then the unresponsive teen. Oh, this is going to be terrible. Drugs, overdose, suicide. Oh no, it's going to be terrible. It's a gunshot wound. Maybe I need to worry about that. And this is going to be terrible. Will I know this kid? So what we're going to talk about today is the response to the unresponsive child. And we're going to go through the 3 different major age groups and kind of discuss the pluses and minuses, the things to do, the things to be aware of, and the things that you don't want to miss. I'm Paula Fink-Koken. I'm one of the ER docs at Minneapolis Children's, and I'm the medical director for Minnesota Emergency Medical Services for Children. And today is National EMSC Day. So just a little bit background on EMSC. EMSC is a federally funded program that is represented in each state. You write a grant and you get funded, and then the purpose is to kind of make sure that children are taken care of completely in the EMS globe all the way through into the emergency department. Our mission here at Minneapolis, or Minnesota, is to ensure that all children in Minnesota receive the best pediatric emergency care in the event of severe injury or illness. And as I said, I'm the medical director, and then Chelsea Polzine is the manager, and this is her email address there. So if you need to get a hold of her or something, go ahead and take a picture of the site, and you can know that. And just a little bit of an advertisement. We are recruiting pre-hospital PEDS champions in our state. So if you like PEDS, if you seem to think that's a focus for your care, give an email to Chelsea. And a PEDS champion is the designated individual that ensures that their EMSC agency and the providers are better prepared to take care of sick and injured children. And as I said, it's not a very onerous thing. You don't have to spend lots of time, but we want to have someone to reach out to when we have changes in pediatric care and such. So that's EMSC, and I hope you have been having a good EMSC day. So we're going to go on to the case. Our goal in this talk is to talk about the causes of unresponsiveness according to the age group. We're going to go through pediatric infant, child, and teen, and the majority of the time we're going to spend on the child. So we'll talk about the causes, and then we'll talk about the unique aspects of treating each patient in that age group. And then hopefully by discussing this, we can decrease your concerns, your anxieties about going to see an unresponsive pediatric patient. So the first thing that I find helpful in taking care of a patient that I don't know much about yet is to start making a list in my mind as to what could be the cause of the patient's problem. And so knowing the age of the child and the location where that happened helps you a little bit. So if you're called to a scene at a playground, you know it could be a trauma. If you're called to a scene at a house or a school, it could be a seizure. So starting to think about it in that manner. And then thinking about what do I need to do to help that patient go through. So going back to the rudimentaries of A, B, C, D, and E, how will I do airway management in a child? How will I handle breathing? How do I handle circulation? Will I need an intravenous line or an IO, or just need to bundle them up as best I can and put their feet up so that they're not going to suffer from shock? And then what type of equipment, extra equipment do you need? Do you need the C-collar? Are you going to be able to transport the infant safely? And then finally, where are you going to transport the patient? Is it going to go to the nearest ED? Is there an ALS intercept? Is it air transport? So those are the things that you start making a list early on. So regarding the causes of pediatric unresponsiveness, this is a big list of all the ones that cause immediate unresponsiveness and that you'd have to take care of in the EMS world. Head trauma and CNS is one whole category, and then everything else. And we're going to kind of talk through each one of these according to the age group. So first off, the infant. And the things that happen with infancy, we worry a lot still about trauma and seizures and infection. CNS infection like meningitis. Trauma would be things like either car accident or non-accidental injury like shaken baby. And seizures. Other CNS concerns like neoplasm and vascular disease like stroke and hydrocephalus are very rare in the child that would cause it emergently to have unresponsiveness. The things that cause other problems that are not necessarily related to the head and the CNS is more hypothermia and hyperthermia. And I was very pleased to hear the talk previous to this on hypothermia. Definitely on kids, they get cold very fast, both in trauma and non-trauma. So be aware that the child may be cold and not even be from being left outside or anything like that. Hyperthermia is when we're dealing with a child with both fever and environmental hypothermia. And then hypoxia. Hypoxia in the infant is the major cause of respiratory distress and failure and cardiac failure. So usually it's respiratory that leads to failure to get enough oxygen in, and then a cardiac failure. So hypoxia is a major cause of decreased responsiveness to the infant. Intoxications are not that great in infants, although I have had parents give the wrong medications to them. And then metabolic abnormalities, usually not diabetes for the infants, but they can have other metabolic inborn errors of metabolism that have not come to light yet in their short life. And then sepsis and dehydration are major causes of unresponsiveness for the infant. And as I said, the majority of our talk is going to be related to the infant, but we're going to touch on the child and also on the teen. And so the child, we've already got the lesser known causes listed up here, like infection and neoplasm. But again, with the child, trauma and seizures can happen. And then hypothermia and hyperthermia and hypoxia. Again, hypoxia is a major cause of unresponsiveness and cardiac arrest in children. First you get the respiratory distress, then you get failure, then you get cardiac failure. And then finally, this is when you'll see the intoxications, both accidental and non-accidental, and also diabetes will start showing up. Most children present their diabetes as DKA, and they'll oftentimes be unresponsive and breathing very heavily. And then dehydration in a child is very common due to fluid loss from diarrhea and vomiting. And then the teen, we're going to leave up the things that are not really common, but as you all know, trauma and seizures is big on the teens. And then again, hypothermia and exposure. Hypoxia is still a big situation, and airway obstruction, which would be foreign body from goofing around and playing around with unusual things to try to swallow and hold in their mouth. And then intoxication is one of our major causes. And finally, DKA. So on the major ones that are the worst that which we see with unresponsiveness is usually the post-ictal state, so after seizures, trauma, ingestions, hypoglycemia, hypotension, hypoxia, and then for the infants, SIDS, and the other mnemonic is the new words for SIDS. I always forget which one it is, so I threw it up there. I'll have to look it up again next time we talk about this. So what can EMS do? Well, you can treat certain things, and other things you can't necessarily help out too much with. The ones on the left are the ones that you can pretty much help out and almost get the child back to a very good, stable situation. And those are the hypoxia and toxic ingestions. The things that you can't necessarily do much about, we do get intracranial hemorrhage in children. We also have neoplasms, cerebral infarctions, BP shunt problems, and sepsis. Those are mainly the load and go. But for the things you can treat, with hypoxia, you all know, the biggest thing is just adjusting the airway, and we'll talk more about that in just a few minutes. And then getting oxygen on them. There is no concern with pediatrics on giving too much oxygen. Perhaps the newborn baby, when you don't want to give them 100% oxygen, because that can cause problems, but when you're taught with congestive heart failure adults and not to give too much oxygen, pediatrics is not that. We give oxygen to everybody. So the other thing for EMS action is looking for a foreign body and trying to relieve that. Toxic ingestions, and our main ones are opioids, so you can treat it with Narcan. Hypoglycemia, and you can treat it with glucose. Trauma, and that's back to the first talk, stop the bleed and C-spine immobilization and transport. Hypothermia, and giving them warm packs and covering them. And then finally SIDS, and that one would be starting CPR. So what we're going to do is go through each of the age groups and talk first about the unresponsive infant, then the unresponsive child, and then the unresponsive teen, and the unique aspects for each of them. And the most easy way to figure out how to handle the infant is to go back to the pediatric assessment triangle. If we remember that, it's got the three sides, appearance, breathing, and circulation or skin color. And appearance is pretty much level of consciousness. How are they doing? Are they awake? Are they interacting? Are they cooing? Now, you're going to be fooled at times with a sleepy child because they might be a little out of it, but they should respond to you. You know, the nice part about pediatrics is if they're crying when they come in, that means they're probably not too bad off. And so we love to hear the crying child, even though it can get to you after a while. Breathing is the work of breathing and how well they're passing air through their airways, and circulation and skin color shows us cap refill and that type of thing. And then the little triangles on the side kind of show you where you've got your respiratory distress is only with breathing, but then when it gets to be respiratory failure, they're pale and lethargic. And then CNS is just appearance or loss of consciousness, while CNS and shock would have decreased perfusion of tissue. And the final one, if you've got all three as compromised, you've got cardiorespiratory failure and you're going to need to do CPR. So going with a child, infant airway assessment. If the airway's open and you can hear breath moving easily through and the child's not working hard to breathe, then you can go straight on to breathing. But if there is no airway going through and no spontaneous breathing, then we need to adjust it. And we're going to show that in just a minute. I'm going to show you a couple diagrams, and then I've got a couple mannequins here to show you the patients and how you should adjust their airways. So the diagrams show the difference between the pediatric and the adult airway. And if you look at it, there's in the adult airway, there's a lot of room right behind the tongue. But with the pediatric airway, the epiglottis is very high in the oral pharynx, and it doesn't take anything for the child to have that tongue fall back. If you add in a lot of the large tonsillar material that is in a lot of kids, they've got hypertrophic tonsils almost all over the place. You can have lots of airway obstruction just due to anatomical problems. And so the pediatric airway is fraught with all sorts of blockage. And as it shows here, that the child also, according to their physiological makeup, they have this big occiput on the back of their head, and we'll show that in just a second. And that pushes the head forward so that it blocks the airway, and then the tongue kind of falls back in that airway site. Picture B shows a towel or something rolled underneath the child's head or underneath the child's shoulders, and then you get a better airway. So I'm going to walk over, and I've got a couple of mannequins here. So this is a child mannequin, and if you notice, the head of the child mannequin has this big occiput, and when he's lying on the table, he's pushing his head forward with that. And so if you're going to try to bag the child with that, you're going to have trouble because you're going to not be able to get air into the body because it's going right into the back of the throat and coming back at you. But if you take your time and adjust it for the child, then you can use this towel and kind of have it at the shoulders and having the head kind of hang down a little bit more so that he's able to open his airway better. And I've got a small oral airway. Again, this is an unresponsive child, so we don't have to worry about the child not tolerating the oral airway. And then we're going to go ahead and do the C and E and get better aeration. And you guys can't see it exactly, but I've got full aeration going into this mannequin with that adjustment. Also, you'll want to do a little bit of a sniffing position. So you're going to have the head kind of forward and the head, the face forward and the head back like that. But that opens the airway immensely. Trying to do it without the towel and even trying to do it yourself, like you're trying to move it, is like working against everything. And also you're mashing on the back of the head, which is no fun. On the older child, so say this is more of like a 3-year-old, even though the 3-year-old doesn't have quite as pronounced a occiput, they still are ending up with their head kind of tilted forward and kinked forward, and so the airway is just blocked slightly. So in this situation, again, you would want to have the child with their, as I bonk the kid's head, with the towel underneath the shoulders so that you've got just a little bit of movement, and then you've got your oral airway in, and you've got your hand covering it, and you're going to be able to ventilate the child that way. So adjusting the airway, just adjusting the airway will buy you time too. That's the other thing. You don't want to go and try to intubate every child that you've dealt with who has an airway problem. If you can adjust the airway so that it's open, then you've saved yourself the intubation and you can help them out in their breathing. So is the airway open? Another thing is these kids very often get a hold of all sorts of toys and button batteries and magnets. I had a 7-month-old the other day who came in with a button battery that was about the size of a nickel stuck in the esophagus right below the oral pharynx. And you wouldn't think that a 7-month-old would have put it in their mouth, but they did, and luckily they were able to get it into the esophagus as opposed to the trachea. But if you have something stuck in the airway that you can see and is blocking the passage, go ahead and remove it. The paramedics, I believe, are taught to use McGill forceps to try to grab it and pull it out. If you see it and you think you have long enough fingers to grab it and pull it out, that's probably all right. Do not just sweep the mouth. We used to teach that you would sweep the mouth to try to get out any foreign body. And nowadays, we don't want to do that because you might push it down further. But if you're not getting good air passage, look for foreign body. You can try both for the babies, the 5 back blows and the 5 chest thrusts, or you can try with the older children, the Heimlich and such, but if they're unresponsive, you should go on to chest compressions. After you've got through the airway, and either you're doing chest compressions because you've got a blocked airway or you've got it open, we're going on to breathing. And so breathing, if breathing is adequate, that means they're not gasping, they're having minimal amount of work to push forward their breathing, and they're getting better capillary refill. If they are not doing that, go ahead and do bag valve mask ventilation. When the child is not breathing and you've got a good airway, it could be, even on the infants, that they've gotten a hold of something and perhaps they have opioid ingestion. And for infants, we're even doing naloxone, and the amount is 0.1 milligrams per kilogram IV, or still 1 milligram intranasal. This is the American Heart Association 2020 opioid poisoning algorithm, and I just wanted to kind of point out that if this is our child, we're going down the right side of the algorithm, and so the child's not breathing normally, but perhaps has a pulse, so you're going down to the green, and then you do bag valve mask and give naloxone. In the patient who does not have a pulse, you treat them just like a regular child who has cardiopulmonary failure, and you'd start CPR, and then if the situation is indicative, then you could use naloxone. So you've gone through the opioid concerns, and now you're doing ventilations. If they're improving and their airway is good and you're getting color change, go on with circulation. If they're not improving, then you would go on with CPR. So circulation, if they've got palpable pulses and good cap refill, then get your transportation started. If they've got poor perfusion and their cap refill is greater than 2 seconds, then you might consider putting an IV in or an IO. And we're doing normal saline primarily, 20 mils per kilogram. And if the heart rate remains low at less than 60 and the child has poor perfusion than doing CPR. And this is the 2020 Pediatric Advanced Life Support CPR algorithm. And I'm not going to go through it all. I'm sure you've all been through it, but it just talks about doing everything very methodically, starting with the A's and going B and C. And as we know in EMS, we've got D&E, exposure and disability. And for that situation is you're going to check glucose. Children have very poor glucose stores. And so oftentimes we'll have children brought into the ER who have been having vomiting and diarrhea, and the parents truly think they've been keeping them hydrated and giving them glucose-containing fluids, and we'll check a glucose on a very somnolent baby or a 2-year-old, and their glucose will be 40. And then we give them glucose, and it's like night and day. They're suddenly awake, they're alert, they feel much better. So check a glucose when you don't know what's going on. We are using for the infants either D10 or D25, infants and small children. The reason why we use a more dilute form of dextrose is because when you give D50, it circulates in the body as a bolus, as a solid, like a small lozenge of D50, and it doesn't diffuse very quickly, and it has caused cranial strokes. And so with the younger children, infants especially, and also the little bit older children, make sure you're using a more dilute form of D25 or a more dilute form of D50. And this is the one of the recipes on how to make D10 out of D50. If you want to take a picture of that with your cell phone, or I can send my slides to you if you send it to either me or to Chelsea at EMSC. But it just is an easy way to give a little bit of fluid, or if you've got D10W, you give 3 to 4 mils per kilogram. Also on the D&E is exposure and looking at them. Remember, just as in the previous lecture, it doesn't take much to cause a child or an injured person to become hypothermic. So make sure you keep them warm, but do expose things. Remember inline stabilization and transport. One thing to be aware of that you have to kind of make your decisions in your brain is that children who have non-accidental trauma and cerebral hemorrhage from that can look very similar to opioid overdose patients. They are drugged, they have decreased level of consciousness, they may be out of it. And so be aware that your child that you think might have some overdose or toxin might actually be a non-accidental trauma. And in those cases, we'd want to make sure you had a C-spine and look for signs of abuse. The signs of abuse that you might see on an infant would be bruising where you don't usually see bruising. On infants especially, you'll see bruising around the ears where they kind of use the ears to grab the child. Bruising or swelling of the limbs that on a child who is not able to walk yet. So think about that and make sure you're aware of non-accidental trauma as a cause of decreased level of consciousness. Opioids are not the only drugs that these kids get into or that are accidentally given as medications. I've had wrong medications given to the kids. I've had medications of cardiac medications that were for one child given to the other child by mistake. So be aware that the patient may have an accidental overdose that is not an opioid, and they may not respond to your Narcan. So just be aware that if you've got them stable or if you can't do any more, go ahead and bring them on in. So transport. It all depends on what your protocols are as to what your transport would be. If it is trauma and the child is really out of it, you need to go to some place where they can stabilize them. If it is a patient who is breathing and beating okay, so you've got good oxygenation, good color, but they're just out of it, you can choose where you want to go, where you think they should go, because they're stable for that time period. And that's probably the biggest thing, is to determine, is the patient stable? Can you take them to a tertiary care center that might be further away? Or is the patient not stable and needing to go to a intermediate area where they can be stabilized and then maybe flown out? Other pertinent information on these children are, is this a child with special needs? Is it a child who has a trach? Is it a child who has, who is confined to a wheelchair? Is it a child who is on numerous medications? So make sure you think about that and get your get the family member or whoever's with them to give you all the information they have if you're going to leave, especially if you're going to leave that family member behind and transport the child. And kind of take a good look at the circumstances where you found the child. Does it look like they would have gotten into an opioid? Does it look like they could have fallen from somewhere? Kind of do a little bit of investigation. So now we're going to go up in age a little bit, and some of this will be a little bit redundant from the infant to the child and child to the teen. And as you know, it's all a progression, especially if you're a parent. You've known that these children slowly mature, but there's still fallback all the time. So airway again, you're going to think in terms of your plain old A, B, C, D, E's. If the airway is open and they're breathing, you can go on. If the airway is open, go on to breathing. If not, look at the child. Again, children, adjust the airway. My colleagues in the ER are very keen on if the child is, say, having severe airway obstruction because of mononucleosis, and all you have to do is do a little bit of a jaw thrust and they can breathe just great, good. Or if you need to put in a nasal or oral airway and they can breathe, then do it. If you attempt ventilations and there's chest rise, go on to breathing. Don't forget C-spine precautions. And then, as I said, foreign body. If you see it and you think you can remove it, go ahead and try. But if you don't see it and you can't get air past there, then start compressions. Just a word to the wise, back in the days when we had epiglottitis, we always worried about airway obstruction. And one of the things we found was that when the child is more relaxed, even with a large airway obstruction, we were able to ventilate pretty well by using a lot of force trying to push air through. So before you think you need to do like a crike or something like that, try just positioning the airway numerous different ways and trying to get a good seal. If there's no airway passing, then start CPR. Breathing, bag valve mask. I think the biggest way that you know, what is it? The biggest, I can't think of the word, way to get a patient to get better is to know how to bag valve mask effectively, to get the seal. And if you can't get it the seal with one person doing the bag valve mask, get someone else to squeeze the bag and you hold the mask. It's the way to save many patients, and you don't need to worry about intubation. You can bag till Monday if someone will bag for you and you'll hold the seal. So talent, that's it. I was thinking about the best talent to know is how to bag effectively. It will save you in many, many ways. Circulation, again, in this situation, you want to do CPR if the heart rate is less than 60. If it's ineffective circulation at greater than 60, then give fluids. We're doing normal saline, as I said. And then disability in the older child is using D25, usually 2 mils per kilogram. Be aware that in this older child age group, oftentimes these kids will be post-ictal. And those kids are, if you can just open their airway, maybe put an oral airway in, give them oxygen, they do just fine. You don't need to give more anticonvulsants to the child who stops seizing and is just post-ictal. Consider non-accidental injuries on these kids. And then again, naloxone, pretty much we're going, it's still 0.1 mg per kg for older children of naloxone, but you get pretty quickly to 2 milligrams. So it'd be 2 milligrams IV or 1 milligram nasal cannula. So now the unresponsive teen. And these, I think you probably feel a little bit less scared about, but it's still a worry when you hit them, when you get to those guys. Again, is the airway open? Adjust the airway. You don't have to worry so much about the occiput being big in these kids, but just jaw thrust or adjusting things. As I said, if they're awake and just kind of somnolent, you can try a nasal airway, and those will work really well. The other is if they're out of it, an oral airway and bagging, or oral airway and just opening things up. Get ready for vomit. These kids oftentimes are overdoses, and so they're going to be vomiting all over you. Make sure that you get your suction going and have it ready at the bedside. And again, remember, no blind sweep, not asleep, sweep, because you don't want to push things down. Breathing, if they're breathing well, go on to circulation. Use your protocol for naloxone. And then if they have stopped seizing, they don't need any anticonvulsant medications, so don't give them more. We've had many a child that we've been sitting in the ER for a long period of time, waiting for them to wear off their Versed that was given en route because they looked like they were seizing again. You can let them, you can see if they're going to go and fully seize for you before you give them a second dose. And then circulation, be aware of trauma. Get your inline stabilization. And then for disability and exposure for glucose, this is where you treat them just like an adult, usually 50 mils of D50, and be aware of the postictal state. Consider trauma, abuse, suicide. Look at all the circumstances that you're picking the child up from. And then transport. Determine whether you're going to go to the nearest ER or to a pediatric center. Oftentimes, if it's a child with special needs, ask them where they get their care. It will really help out the ER doc if the child is stable and is at the place where they usually belong, because they have all their records and they also have all their subspecialists. So they usually can figure out what's going on. If they're on a lot of different meds, bring the bag of meds and look into the circumstances that you found the teen. So this is about, wraps it up for the talk. We looked at the causes of unresponsiveness in different age groups. And so hopefully you feel a little bit more comfortable with the fact that the infant, you're worried about non-accidental trauma and respiratory failure would be the major causes of unresponsiveness. In the child age group, post-ictal and accidental ingestions, and in the teen, trauma or overdose. And what you could do about them, what makes them unique, remembering how to set up the airway and open the airway, being aware of the occiput, using everybody you can to help you out with them. Become a talented bag valve mask provider. And with a child, foreign body in the airway, knowing when to go for it and when not. And then for the teen, repeating naloxone doses. I didn't go into the heavy use teen or heavy use exposure to opioids that you might need to give lots of naloxone. But that would be repeating it if you're not getting much response and you are pretty certain things are happening. And then post-ictal, you don't need to give meds only if they're still seizing. So by discussing the causes and what you can do, you should feel a little bit less anxious about this pediatric call. So, questions? I think go ahead and put them in on the chat and they'll relay them to me. And if you have questions that are not quite related to the talk, we can talk about it as well.
All right, thank you, Dr. Koken. I do have a couple. Kaylee Fallis is asking, what is the best IO location for a peds? She's heard conflicting between distal femur and proximal tibia on infants.
On infants, so it depends on how big of infant you have. If you have a newborn or a preemie or such like that, proximal femur would be the wiser area. If you have a big 7-month-old, then tibia, but it kind of depends on what you feel, how big you think the bones are at that point.
Okay, Justin Volkner is asking, what can we use if you can't give D10 or D25? Can we use D5?
Yes, so but you're gonna be giving more of D5, so just multiply times 2. So if you have an infant who is hypoglycemic and you know it, it would be like 8 mils per kilogram. So if it's say it's a 6 kilo kid, that means you're going to be giving like 48, 50 mLs. So it may end up a lot if you don't have D50 that you can dilute, or so just be aware it's going to be a lot. And you can also, in the child who's not completely unresponsive, you can give oral glucose. You can, give sugar or sweeties, or, even if you have suckers, in a child who's not quite out of it, who has a good airway, protect his own airway.
Okay, thank you. Donald Hannes is asking, when administering glucose to a patient with a possible closed head injury due to trauma, would it be best to use D5 or D10?
Yeah, it depends on how much fluid you're giving, and I don't think it really matters too much between those two. I think it more matters if you're going to be having a small child and do D50. Yeah, I don't think you're just going to get into more volume, as I said, somewhere around 8 to 10 mils per kilogram to get the sugar up.
Okay, Jay McDonald's asking, for an EMS basic crew, would you recommend the use of glucagon since IV D10 is out of scope?
So glucagon is out of scope as well? Did they say?
Yeah, since the IV D10 is out of scope, would you use glucagon?
Yes, you could use glucagon. It's an IM shot. It depends on if you have that as a protocol. Recently, the price of glucagon's gone up, and so not as many people are carrying it. But if you still have it, then yeah, you can always use glucagon if you've shown that the glucose is low, especially on our diabetics who may have had a little bit extra insulin and didn't eat or didn't feel good and didn't get their food in, and their sugar is like 20. Glucagon's a good shot, good solution.
Great, and Frank Mitchell's asking, what is the preferred source for obtaining temperature for infants?
So the gold standard is rectal. However, at times, especially when you're trying to go somewhere and transport the child away, you can still use axillary. Just as I talked about in the previous lecture, make sure you get skin to skin and that you leave it on long enough for the electronic temperature to acknowledge that they've got the temperature. It's just important that when you record it, that you record it if it was axillary or if it was rectal. The axillary seems to lag behind, and so you'll have say 103 kid whose axillary is 99 and their rectal is 103 at the same time, and it just is that the body hasn't caught up yet. So so if you can get the rectal, great. If you can't and you get a axillary, the important thing is to note it. I'm not a keen fan of the forehead electronics or the ear thermometers. If you read the fine print on the ear thermometers, they say you're supposed to take 3 different readings and kind of average them all. It really, you have to get used to them, and also in a situation where you've got an unresponsive kid, that's probably hard to get. So so I would go axillary or rectal.
Okay. Another question by Kaylee. Not sure if she's missed it or not, but the blood pressure for adults,
Oh.
we want about 90. I know with each age, all vitals are different. For peds, what's a good baseline for trauma, especially?
I think the problem with peds and blood pressures are until you get to be like about 8 or 10, you're not going to get a good blood pressure regardless. So I would go more on perfusion and cap refill. And that's kind of what we do in the ER. We see their blood pressure, but 80% of the time they're high, 20% of the time they're low. They're rarely, and they're really accurate. If you have a long transport, you can kind of gauge it as where you're getting, where things are going. But I would, I think it's 80 is your systolic for an infant, and then 90 for older, and then 100 when you're getting to like age 10 or 12. So as I said, in the ER, I really don't hang my hat on blood pressures unless they're trending one direction or the other. So it's more on perfusion and mentation.
Okay, I don't have any additional questions right now, but if anybody else has any, now would be the time to send them in.
And as I said, if you or you know someone who would like to be a PEDS champion for your agency, contact us at EMSC. Our website is getting redone, and it should be done in mid-June, I hope. And so you could contact us through the website, but it won't be up to really, there is one currently, but it's not a great one. You can also contact Chelsea, or you can contact me, and we can get you hooked up to be a PEDS champion.
Okay, I've got 3 more questions.
Mhm.
If you have a 7-week-old infant called Blue and not breathing, CPR is needed, the pediatric pads take up their whole front area. Do you do compressions over on top of the DFED pad?
Yeah, or you can put them front to back. You can put one pad on front, one pad on back. If it seems like, and you don't want them touching anyway. So if you do feel like you need to do defibrillation, you can put them back and front, and then you can do CPR on top of that.
Okay. The other 2 questions were just asking for your email. Sorry about that.
That's okay. So yeah, if you have any questions, don't hesitate to get a hold of us, and happy EMSC Day.
Great, thank you very much.
Mhm.
Our next presenter will be starting, they think 8 o'clock, but possibly sooner. So go ahead and take a short break, everyone.
My name is Janet Taylor, and tonight we're going to talk about crush injury and crush syndrome. Crush syndrome is actually, goes by different names: compression syndrome, Bywater syndrome, Meyer-Betz syndrome. A bunch of other different names have been given to this syndrome because it's actually been recorded several different times throughout history. Doctors, in the 1800s, beginning in the 1800s, started talking about these conditions in which their patients who had blunt injuries would develop these 3 classic signs of muscle pain, extreme weakness and fatigue, and brown urine. This started in the late 1880s, and there wasn't really a name given to it at the time. They just couldn't figure out what was going on. And in 1941, the British Medical Journal actually gave it its official name of crush syndrome when soldiers from both World War I and World War II actually were reporting to the medical ward after having bomb concussions, blast injuries, or being thrown far away from an area and landing hard on their bodies. 3 days later, they're in the ward with muscle pain, weakness, and brown urine. So they gave it crush syndrome the name in 1941. Now, there's 2 different things here: crush injury and crush syndrome. 2 different things. The mechanism is kind of the same, but we want to be able to differentiate between this, okay? Crush injury is very, very simple. It's very quick, and it's probably the only time we'll talk about it is this one slide, okay? So crush injury is where you have cell disruption or cell injury at the time and location of impact. That is the very moment that you have impact with something, and that is the very location. So I like to describe this as if I were to slam my hand into a car door. At the moment that car door hits my hand, that's the point of impact. That's the amount of injury that has occurred. The injury is not going to get any worse because I'm opening the car door. The injury doesn't go any farther than my hand. So it's very localized. It's very, very short. It's only at that point of impact and you're done, okay? The course of time is instantaneous. Now that's injury. I can have a crushed hand with a crushed injury and I'll be okay. You know, I might have broken bones, but really it's going to stay in my hand. So crush syndrome is a systemic effect of that cellular injury, cellular disruption. It's huge masses of cells, like muscle cells, that are compressed over a period of time and released. So it's not instantaneous. It actually takes several minutes. Now, I have in here 15 minutes to 1 hour because it depends on what your resources say. Every book's a little different. We have articles out there that say it takes 15 minutes, and others like it has to take at least an hour. It depends on what book you read, okay? But I want to make sure and put that in there that according to the definition of crush syndrome, it's not going to be at that time of injury. It's going to take some time for it to develop. Now, there are exceptions to crush syndrome. People who are elderly, who have very poor circulation, people who have endured lightning strikes, or those who have endured bomb or blast concussions could develop crush syndrome and not have had that long period of time in which their cells are under pressure. So there are some exceptions to the rule. I just want to make sure that you understand that. We're going to revisit some of this here in just a little bit too. So the mechanism of injury, it could be just about anything. I tried to list some of the more common ones though. Building and structure collapse, you know, definitely with the earthquakes, we would see, excuse me, we would see people crushed under rubble, concrete. Construction accidents in which a construction worker is under a heavy weight of some sort for a period of time. MVAs, farm accidents, and then assault with a blunt weapon. Particularly assault with a blunt weapon with a large surface area. The larger the surface area, the more mass you're going to affect. So you're going to have a worse crush syndrome if you were attacked and beaten with a baseball bat than with a piece of rebar, because the baseball bat has a larger surface area. So other considerations would be immobility against a firm surface. Now this goes back to your elderly patients and your patients with poor circulation. Any of these conditions listed below could affect that and could cause you to be immobile against a firm surface. If you were on drugs, if you got drunk and fell down and passed out, carbon monoxide poisoning, having a stroke, the old fallen and can't get up thing, right? Prolonged surgery keeps you from being mobile because it hurts to move. So you'd just rather lay still in bed and just not move than have to get up. And then passage or mast pants, hardly, I don't know that they're ever used anymore, but I want to make sure and put them in here because surely somebody out there is using them. I don't know, but I want to make sure and put it in here. Anytime you're going to be laying on a firm surface for a period of time is going to affect your severity of crush syndrome. Now, the determining factors. Every time I give this, people want to know what's the mathematical formula. There is no mathematical formula. There are 5 different variables here, and each one is different. Each one contributes to developing crush syndrome. The time underneath the object, we talked about that, but most books say anywhere from 15 minutes to at least an hour. So the time underneath an object, the weight of that object, the surface area of the object. Let's think about this. If I have a cinder block that is on top of both of my thighs, well, that's not as much surface area that's covering my body as maybe a small car on top of my thighs. Same thing with the weight of that cinder block versus the weight of a small car. So again, there's already 2 variables that are making a big difference here. The patient's predisposed conditions, if they have cardiac disease, liver failure, renal failure, and just overall poor circulation, they're going to be more at risk for developing crush syndrome, even if they are under the same conditions as someone else who is maybe younger and healthier. So a 24-year-old healthy person can be laying there, and an 80-year-old person with poor circulation can be laying 10 feet away with him. Same time, same weight, same surface area, same object. that 80-year-old is going to have a lot worse outcome than the 24-year-old. And then anatomy involved. Here's a big one. I want you to think about this, okay? I mentioned my hand being crushed in the door, and that would be crush injury. It's focused on my hand because my hand is muscular, but it doesn't have a lot of muscle, not like maybe the top part of my arm or the top part of my thighs. So the anatomy involved in which you are more likely to develop crush syndrome would be your upper arms, okay, your upper legs, your thighs, your abdominal muscles, and your butt. Think about that. Those are large areas of muscle mass. So yes, if I'm laying immobile on the floor, one of these body parts are going to be pressed. If I'm laying on my side, my upper arm is going to be pressed on that linoleum floor. If I'm laying on my belly, my upper legs and my abdominal muscles are going to be affected. If I'm laying on my back muscles and my butt is going to be affected. So if you're talking about crush syndrome, always think about those large areas of muscle mass that is being compressed and held under pressure for an extended period of time. Now, people see this and they kind of freak out because it's chemistry, okay? But I promise I'll make this easy for you. Promise, okay? Just a little review, and I don't want to hear about, oh, well, I'm just a BLS, I don't need to know this. Yes, you do, okay? I'm going to make this easy for everybody. Inside a cell, whether it's a muscle cell, a cardiac cell, any cell in your body, inside each cell are some things, okay? Potassium is the most abundant cation inside your cell. It likes to stay inside the cell. Now, it'll jump out and jump back in once in a while, but really it likes to stay in. ATP is part of the Krebs cycle. Again, I'm not going to freak you out. Just know it's for energy. That's all I need you to know. ATP is inside the cell and it's for energy, okay? We also have hydrogen and lactate and urea and phosphate. All these things are supposed to be in a normal, healthy, well-perfused cell. Every single cell, okay? Now, when they are oxygenated, healthy, circulating, all these things, they have functions in your body, and that's what keeps us at homeostasis. However, if we are destroying these cells, or if we are depriving these cells of circulation and oxygen, then chemical things change, okay? Potassium stays like potassium. ATP is an acid, okay? Hydrogen is an acid already. Lactate, when it is deprived of oxygen, becomes lactic acid. Urea, when deprived of oxygen, becomes uric acid. Phosphate, when deprived of oxygen, becomes phosphoric acid. We're getting a theme here? So inside our cell, we have these necessary substances, but if we can't get them oxygenated and keep circulation going, we're going to have acid potential, and it makes a sludge. Okay, so I want you to remember that. Okay, we've got our cells, we got some stuff going on. Everything is all great until we deprive that thing of oxygen. Myoglobin is another thing I want you to know about, and we'll talk about this closer to the end of the presentation. But myoglobin is a building block of muscle. If you see up here in the upper left-hand corner, it kind of looks like the spiral of a notebook. And that's what myoglobin looks like. It's protein building blocks that are in spirals, and they give muscle structure. They give muscle bulk, okay? Myoglobin should never be in the bloodstream. It belongs in your muscle tissue. But when muscle breaks down, myoglobin can be absorbed into the bloodstream, and that's okay for a little while, all right, as long as it remains dissolved in the bloodstream. Once it's exposed to an acidic environment, it changes form. And I'll explain more about this here in just a little bit. But right now, I need you to know about the cells and myoglobin. So I'm going to go super, super, super slow motion, okay? We've got a weight coming down, super slow motion. That weight hits a person's body. Let's say they're laying out there on the ground and a big car comes down super, super slow. As that weight presses down, it starts squishing fluid out to areas that it's not going to be covering. Just like if you were to have a full sponge and you mash your palm into it, water's going to go squirting out the sides. Same thing with your body. We're full of water. Our weight is coming down, down, down. It's going to start pushing fluid out and away from anywhere that it's not touching, okay? Now, as that weight increases, so the weight's coming down, it's pushing fluid, and it's still coming down because of gravity. Now we've got increased pressure on our tissues, and we start having problems with those cells because those cells are under a lot of weight. And eventually that weight increases to the point that those cells pop open. No different than stomping on a bunch of grapes, right? The contents of those grapes are going to be squirting out the sides. Okay, so we've got fluid sequestered, we've got our cells that are under pressure and they're popping open and they're spilling all their contents. Remember what those contents are, right? Potassium and all these things that, if not kept in a pristine environment, will turn into acid. Now, the final thing that happens is that weight's down now. Okay, it's come down, it's increased its weight, it's done. What's done is done. Now it's just sitting there. As that weight stays down, we get blood that's trying to flood to that area that's under the weight, because that's what our body does. We get injured, blood rushes to the area. Well, we've got a problem. That blood can't get to that area underneath that weight, depending on the weight of the weight, right? And the surface area. So as that weight stays down, blood floods to the injured area, and then we release histamine. Histamine is a very important thing in our body. It does a lot of stuff. It makes us miserable during allergy season for sure. But in this case, histamine is a potent vasodilator. That's right. Histamine will vasodilate you. Just like if you're in an anaphylactic reaction, you start feeling weak and dizzy, it's because your vessels are vasodilating and your blood pressure is dumping. That's what's happening in crush injury. Histamine's being released in huge amounts, and now we're vasodilating and our blood pressure is dropping, but we don't really see that yet because we have all this weight on us that's kind of acting like a pressor, really, okay? So we've got vasodilation, but we're not seeing those effects yet. We've got that weight on us. And another thing that histamine does is it increases capillary permeability. Your capillaries are smooth, slick, shiny walls that fluid passes through, okay? Histamine causes those walls to open up like a sieve and they become leaky. And so they start leaking out the plasma portion of blood into your tissues. Well, we've already sequestered a bunch of fluid from our tissues when that weight came down, and now we're leaking more fluid into our tissues. So now we've got swelling everywhere there isn't a weight on us. So we've got a lot of complex things going on right now. Now, human nature makes us think, okay, if somebody's laying there and they've got a weight on them, let's lift the weight. That's just human nature. And really that would work if they had a weight on them and it's only been on them for a minute and we're able to get that weight off of them pretty quickly. That works. However, because of your factors of time and weight, surface area, areas of anatomy involved, predisposed conditions, it might not be the best thing to do immediately. We have some things we need to do to stabilize our patient. Now, we've got the patient, they're laying there, they've got a heavy weight on them. Let's lift that weight, right? What happens is, your capillaries have leaked fluid into your tissues, and then you've sequestered all that fluid out of your tissues also. So when that weight's lifted, all of a sudden we have no more pressure being applied by that weight. We start seeing signs of hypovolemia and hypotension. Heart rate goes up, blood pressure is going down, they're looking really shocky looking, okay? Calcium from our damaged tissues is reabsorbed into those damaged tissues, so our serum calcium levels drop. And when serum calcium levels drop, we are at risk for seizures and tetany and blood clotting disorders. All kinds of things happen when your calcium is not within your normal therapeutic range. Myoglobin from those damaged muscles is suspended in the blood. Now remember, myoglobin doesn't belong in the blood. It can, but it doesn't really like to be in the blood. So myoglobin is now into our blood until it gets circulated to our kidneys. And then our kidneys are trying to pull off all this excess myoglobin, but it doesn't really do it effectively. And then the last thing that would happen is potassium. Remember, potassium is the most abundant cation inside a cell. And if our cells are squished open and laying there underneath a weight for a period of time, we lift that weight, we have a bunch of potassium that has spilled out into our tissues. Well, now our body has circulation again, okay? It might not be great circulation, but it's circulation. Our body is trying to reabsorb all these fluids and acidic sludge and potassium. And as that potassium level rises in our blood, we are at risk for cardiac arrest. You see, the other name for lethal injection in prisons is IV potassium. That's what causes somebody's heart to stop suddenly. That's why you won't see any potassium, IV potassium. You'll never see anyone IV push potassium ever. That's called lethal injection. If somebody's potassium is low, we'll put it in a little bag and we'll put it on a pump and we'll give it over 15, 20 minutes at least. But we're never going to just let that stuff roll in, because a sudden hit of potassium to your heart will cause cardiac arrest. And that's usually the thing that kills patients after that weight's been lifted. Remember, I said human nature causes us to want to lift that weight. And it's in good intentions. You know, people come over and, oh, hey, let's get this weight off of you. Well, let's wait till, let's not wait till the ambulance gets here. We can lift this thing now. They lift that weight and that patient is dead within minutes. It's actually called smiling death, which is kind of morbid, but that's really what it's called. You can Google this if you want to. You'll have to filter out all of your horror movie stuff, but it is a medical condition. And this was quoted by an orthopedic surgeon who was doing a ride time in an ambulance, and they were called out to an entrapment. And they're like, hey, doc, you're an ortho guy. You might be able to help us out here. So he rode along with them. He was conversing with this patient who was trapped. The patient wasn't, completely trapped. He was conscious, alert. He was visiting, answering questions. Everything was okay. They were just waiting on that weight to be lifted. When the weight was lifted, he was quoted as saying, cardiac arrest is almost instantaneous. And it's because when you lift that weight, your circulation is restored. Your bloodstream picks up all that acidic sludge from what spilled out of your cells. It's picking up all that potassium, and it's getting to your heart way too fast. This is an old article, 2013. It's nearly 10 years old. But this was about a New York City student who cheated smiling death after being trapped for 36 hours between two buildings in New York City that are very, very close together. There wasn't enough of a gap for him to kind of wedge himself out. So now we know the assessment. We know what happens on a chemical level, and we all understand this. What are we going to do about this? Okay, we get called out to a crush syndrome. How are we going to treat this? Okay, a couple things. If you have tourniquets and the object is in a nice place where you can get a tourniquet, that'd be great. Let's talk about that car on top of both my legs. If I have a car laying on both my thighs, but you can still get a tourniquet between the car and my pelvic bone, you could put a tourniquet on each of my thighs right at my groin point and crank them down. It's not that you're trying to control bleeding. That's not the point here. What you're doing is when that weight is lifted, that circulation that is restored is going to slow down the rate at which that bloodstream enters back into my central circulation. So it just kind of slows things down. It gives you a little bit of time. Now, I've got a picture of many different tourniquets here. Some of them are not COTC approved. Some of them are. I highly recommend you do your research and find out what tourniquets are COTC approved. That's Committee on Tactical Trauma Casualty Committee. I've got that backwards, but basically it's military approved. Let's say it that way, okay? There are some tourniquets that work really, really well. There are some that really, really don't. So do your research, make sure you've got the right kind of tourniquet. Tourniquets is a whole other presentation I've got later on, okay? The next thing we're going to do is fluids, 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 fluids. PO fluids aren't going to cut it. We need to plump up their volume in their vasculature. At least 2 large bore IVs. If all you can get is IO, that works fine too. The initial bolus is 30 milliliters per kilogram. So you're talking about an average adult male getting 3 liters of fluid as fast as you can put it in. And then afterwards, you're going to do a maintenance infusion based on how much urine they're making. Now, hopefully, by the time you're done with getting the 3 liters in, they'll already be in a hospital and they'll have a Foley, and those nurses can do the intake and output and adjust and all that other stuff. If, however, you are really good and you've got 2 14-gauge IVs and you got that 3,000 milliliters in pretty quickly, give them more fluids. You want to flood their bloodstream with lots and lots of fluids, okay? You're going to dilute down the acid. You're not going to neutralize it at this point. You're just diluting down the acid. You're plumping up their volume. You're restoring circulation, okay? Desired urine output, if you do happen to have a patient with a Foley in, is about 2 to 300 mils per hour minimum. Really, that's not much, because once you put 3 liters of fluid into them, they should be making a lot more than that. If not, you need to be thinking maybe their kidneys are not working. So fluid choice. I want you to follow your protocol. I want you to follow your CPGs, follow your medical direction, absolutely. But I do want you to think about your fluid choice if you have a choice. If your medical director says absolutely only normal saline, then that's what you're going to use. If you have a choice, let's talk about a couple things. Now, what's not on this slide is plasma light and Normasol, 2 other fluids that are very similar to lactated ringers. So those are 2 others that I can actually put in here. Plasma light, Plasmalyte is how you spell that, and then Normasol. They are becoming more common fluids. Before, you only saw them in OR, and now we're starting to see them on the floor now. So lactated ringers is isotonic. Absolutely, we love that. The pH is 6.5. That's a little acidic, especially when our bloodstream pH is 7.35 to 7.45. It has lactic acid in it. And you're like, oh my gosh. Well, that's already part of the acid problem that was in our cells. Remember, lactate turns into lactic acid. However, in this case, when lactate gets infused into your veins and it goes through your liver converts that by taking out 1 hydrogen, and it converts it to lactate, which is a base. It's like bicarb. It will neutralize the acids. So this is great. Now, there's another argument saying, well, now lactated ringers contains potassium and calcium, and we know potassium is going to kill you. Yes, true. And depending on what article you read, the amount of potassium in LR is negligible compared to the amount of bicarb that you're going to get when you infuse large volumes. Depends on your article that you're going to read, okay? I do want you to look into it, though, if you have a chance. Normal saline used to be the golden fluid. Loved it. Normal saline was it. It is isotonic. We love that. The pH is 5. The pH is 5. That's very acidic. Okay, well, we've already got an acid problem. If you do give large volumes of normal saline, you can create this condition called hyperchloremic acidosis. Sodium chloride, you got a lot of chlorine in there, and then you have a pH of 5. You can actually kind of challenge your kidneys a little bit if you give too much normal saline. It doesn't contain potassium, it doesn't contain calcium, so that's not a problem. We just need to be really cognizant of this. If you have a choice, look into what fluid would be best for your crush syndromes. So we've got the weight being lifted. We've given some fluids. How about some calcium? Because remember, calcium was destroyed by the tissue breakdown, and it's absorbed into the tissues during your fluid shifts. So your calcium level in your bloodstream's down, and you can get seizures and tetany and blood clotting disorders, all kinds of things going on. Another thing calcium does that's helpful is it is insurance for your cardiac cells, okay? Some people will say, oh, you give calcium when your potassium's high because it'll lower your potassium. No, calcium does not lower potassium, I promise you. What calcium does do is it stabilizes that cell wall. So you've got a very irritated cardiac cell that's doing this, and if potassium hits it just right, that's it. Your cell stops, and that's cardiac arrest. However, if you've got a really agitated cell and you give it calcium, it soothes it. It stabilizes it so that if you do get a potassium invasion, it's less likely to stop completely. So this is a great thing to do, okay? Tourniquets, yes, if you can. Fluids, absolutely. Calcium, if you got it. Calcium chloride is the most common that we see in EMS because it's cheap. Calcium gluconate, a little bit more expensive. That's why you don't really see it in EMS too much, but either one will work, okay? Calcium chloride, a gram IV push over at least 15 or 20 minutes, guys. You've got that at least one large bore IV. Calcium is kind of caustic to your veins. They prefer it to be given in a central line. We don't have central lines. So yes, you can give calcium in a peripheral line. You have to make sure it's patent. You have to give lots of fluid with it, which, yay, we're giving fluids anyway, so we're going to dilute that down. It will cause them to flush very beet red in their face. That's a normal side effect. Warn them, hey, I'm going to give you some medicine. It's going to make your face feel really hot, okay? Calcium gluconate doesn't do that as bad, but if you were to have that, you could get 10% solution, about 10 cc's over 10 to 15 minutes, and that will also work just as well as giving insurance to your cardiac cells. Sodium bicarb is a fancy word for baking soda. Yes, the box of Arm & Hammer in your cabinet is the same thing that we give in codes. Okay, it's sodium bicarbonate, same thing. What baking soda does is it neutralizes acids. What sodium bicarbonate does in a code is it neutralizes acids, especially in extended downtimes. What it also does is it will drive potassium back into a cell. So this is a good thing. We've got a lot of things going on, and luckily all the side effects that we want happening are going to happen. 1 milliequivalent per kilogram bolus. And then, depending on your protocols, many say put 5 milliequivalents into 1,000 bag and infuse it wide open. Some say 10 milliequivalents. Some say, 3 boxes, whatever. We want to neutralize the acids in their bloodstream, and we want to chase potassium back into the cells, okay? So definitely some sodium bicarb would be great. I do want to mention, though, if you've never tried this little science fair project, the next time you have some expired meds, let's do a little fun here, okay? If you have 2 large bore IVs, that is great. Put calcium in one and bicarb in the other. You never, ever, ever want those two to meet. Now, if you only have 1 IV line, give the calcium first, because that's going to give you the insurance. It's going to buy you some time, okay? Then flush really, 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 really well from above, and at the port that you're at, flush it a couple of times with saline between the meds, because when you mix sodium bicarb and calcium chloride together, it becomes chalk. Literally, that's how you make chalk, guys, okay? If you were to put it in the same syringe, you can actually feel it, and it's hot from a chemical exothermic reaction. So just a little warning here, if all you have is 1 IV, let's flush it really, really well. If you have 2 IVs, separate the meds so they should never, ever touch. So all these things that we're doing, the fluids, the tourniquets, the calcium, the bicarb, all these things, we really want to try to accomplish this before lifting the weight. And again, that's hard to do, and we'll talk about this at the very end. I've got a story contributed to by one of my dear friends, and we'll talk about this, okay? Even if they're not ready, great. It's like, okay, all right, you go ahead and get ready to lift that weight, but don't do it yet. I'll do some things here. If they are ready and like, hey, we're ready, let's do this. And we're like, could you give me a few minutes? Okay. And this is why I feel like it's important to explain this to all levels of healthcare, from first responders to medics to critical care nurses to everybody. Because when we understand what's happening in the body, we're more likely to work together as a team. If I have somebody out there who doesn't understand why I'm making them wait before lifting that heavy weight off my patient, like, what's the deal? Why are you making us wait? Hey, I'm ready and you're not doing your job. Yeah, I am doing my job. You need to understand I have some things I have to do before you lift that weight. If we all know and we're on the same page, we all understand. We're like, okay, hey, I'm ready to lift the weight, but you do your thing real quick and I'll wait on the word go, right? So this is called in the rubble or in the trenches treatment. You're going to get down there next to your patient and you're going to be doing this stuff while the weight is still on them, if at all possible. If nothing else, if you've got a dangerous scene, or if you've got a rapid extrication that needs to be done now, by all means, absolutely, let's get moving, but try to get as much done as possible beforehand. At least get it started so that when they lift the weight and get that patient out of there, you've at least got some things in place, okay? All research shows early intervention and hydration are what saves the patient from that initial lift of the weight. Early intervention and hydration. So we get our patient free. They made it, okay? We got them to the ER. This is great. They've cheated smiling death, right? So they've got, excuse me, they got the weight off of them. They've got their hydration. They've got their calcium. They've got their bicarb. They've got all these things that we've done to try to increase their survival rate, and we did it. We got them to the hospital, okay? They are still at great risk for some long-term complications that we can't possibly help, okay? We can certainly try to prevent that, but what's done is done. So what we can do is the fluids, the bicarb, the calcium, all these other things, I want you to understand what happens in the weeks after we get our patients to the hospital. Now, I told you about myoglobin. That's the building block of muscle. That's the little spirally looking things, right? It's released from damaged muscle tissue. It's absorbed into the bloodstream. And remember, it's not supposed to be in the bloodstream, but it is, okay? So it's floating through your body. It gets to your kidneys. Your kidneys don't really filter blood. Your kidneys filter the plasma portion of blood, really. So it gets to your kidneys, and your kidneys are sponges. They're filters. And what happens when you get large chunks of things in your filters, whether it's your air conditioner filter or your furnace filter or your oil filter, it gets clogged up. Well, these myoglobin proteins are clogging up your filters, okay? The two big risk factors that occur, that make it more likely to occur, are if you have 2 or more limbs that are crushed, or if you have insufficient early IV fluid administration. Those two things together are what make you more at risk for damaging your kidneys with myoglobin. Well, we can't help the 2 or more limbs crushed. We can do the early IV administration. So what happens when you have myoglobin in your bloodstream is you have what's called myoglobinemia. You have myoglobin that is free and is dissolved, and it's floating in your bloodstream, and it's going all over the place. It's being filtered by your kidneys a little bit. What little your kidneys can pull off goes to your bladder, and then you have what's called myoglobinuria. The myoglobin gets pulled out of the bloodstream, gets sent to your bladder where it's mixed with the rest of your urine, and now you have myoglobinuria. That's what myoglobinuria looks like, okay? You can actually chart this as coffee-colored urine, tea-colored urine, or cola-colored urine. That is approved descriptions of what this urine looks like. Usually, you know, pale, clear, straw-colored, whatever. But no, if we've got urine that looks like this, you can describe it as coffee, tea, or cola-colored urine. Hopefully, if you're a nurse and you're watching this patient, you've got them in the unit, you're going to have them for the next couple of days. You're going to give them fluids, and over the course of hours, you can see this urine start to pale in color because you're getting rid of all that extra myoglobin, hopefully. I'll give you some tricks on how to speed that up, though, okay? So how we treat myoglobinuria, luckily it's the same treatment for Crush syndrome, which is aggressive fluid resuscitation and sodium bicarbonate. Okay, so that's great. Sometimes we have complex medical patients in which one treatment that will help this is going to make this condition worse. Luckily, both these conditions work really well together. So we're going to treat the urine, okay? The kidneys can filter or excrete about 5% efficiency rate when myoglobin is floating in the bloodstream, okay? So you have a 5% efficiency rate when kidneys are filtering myoglobin. When myoglobin is pulled out of the kidneys into the bladder and it comes in contact with that acidic urine, because remember, we have acids in our system and they're being pulled up and floated through. When myoglobin comes into contact with acidic urine, it forms a thick gel. Well, that's never good, right? We want everything to go through our kidneys to be very thin and liquid and watery. We don't want thick gel in our kidneys. Now, the treatment for this is bicarb, because when myoglobin hits that acidic urine is when it gels up. Well, let's alkalinize the urine. How do you do that? You give bicarb. We have the excretion rate here. I know this is 1989. This is an old study, but really they've done other studies since then, and they're still finding this same thing happening over and over again. And you know, a validity of a test is when you do the same thing over and over again and you get the same results. So this is promising. If your urine pH is less than 5, you have a 73% precipitation in the nephrons. So 73% of the myoglobin is getting stuck in your nephrons. If your pH is 5.5, it's only 23%. That's just a half a percentage of a pH, but you're already increasing your ability to get rid of that myoglobin. If we can get our pH of the 5, which is still acidic, but it's not as bad as 5. It's only 4%. We actually increase the efficiency rate of our kidneys being able to pull out myoglobin from 5% to 85% just by adding bicarb to our fluids. Other things you can do is albuterol, and not just the 2.5 milligrams. I'm talking about 10 to 20 milligrams of albuterol. I had a crush syndrome patient once, and my medical director's like, "Why didn't you give him albuterol?" Well, my answer was because he wasn't wheezy. I didn't realize that high dose albuterol will increase your body's ability to pull potassium out of the bloodstream. It will actually lower potassium quite a bit. So high dose albuterol works really, really well like this. Other treatments that you may hear being done to your patient, mannitol is an osmotic diuretic. You give it IV and it will pull fluids out of the tissues into the bloodstream. We use it a lot for cerebral edema patients, head trauma patients, some patients who are getting cancer treatments. The chemotherapy is so bad on their kidneys that we give it, and then we give mannitol to hurry up and help our bodies get rid of it really fast. So mannitol is one. Allopurinol is a medication that people get, they take it for when they get gout. And it keeps uric acid from crystallizing. And remember, there's urea inside the cell, and when it's deprived of oxygen, it becomes uric acid. It actually looks like little snowflakes, only they're sharp snowflakes, and it will actually destroy tissue. Allopurinol just keeps the uric acid liquid. It doesn't crystallize. Hemodialysis can be a temporary thing. It pulls off excess acids and potassium from your bloodstream, so that's always good. And then hyperbaric oxygenation is another option if you've got that in your area. Lasix used to be the thing, and it kind of makes sense if you don't think about it too hard, okay? So you've got fluids in your body. You need to get the fluids out of your tissues and into your bloodstream. So let's give Lasix. Lasix will pull up all those excess fluids and you pee, and then you'll get rid of all your myoglobin, right? It doesn't work. First of all, Lasix is acidic, okay? Even though you're only going to be giving them like 40 milligrams, it is acidic, and it only works on the loop of Henle. It doesn't work on your nephrons. It doesn't affect myoglobin. It doesn't really do anything. It does something completely different that has no therapeutic effect on crush syndrome whatsoever. So we don't give Lasix at all anymore. So other special considerations would be compartment syndrome. We will see the effects of compartment syndrome from crush injuries, and we will see crush syndrome from compartment syndrome. So it depends on which came first. We see this with long bone fractures, crush injuries, burns, super tight bandages, overuse injuries. You can also see it with large blood clots in the long bone areas and ortho surgeries. So what happens, and I'll forward to this one, okay? So this is a cross section of your leg. Your arm looks similar, okay? Up here in the upper left, you've got these compartments. They're like little rooms in a house. Each one is completely separated from the other. And this yellow here, that is fatty tissue, but right, these little dots are veins and arteries and nerves, okay? So the white in between each compartment is just a little space. It's a little buffer. You've got circulation to everything here, okay? If you've got compartment syndrome, each of these compartments is swollen and they expand and they try to impede onto the other compartments. And you see what was once white over here is very, very thin. It's because everything is swelling up and there's really nowhere for it to expand. So not only are you swelling from the outside in, all that swelling is also compressing your veins and your arteries and your nerves. So pressure builds up within these compartments and it compresses the nerves and the vessels. It can occur several hours after an initial injury, actually up to 72 hours after an injury like a femur fracture or a tib-fib fracture. Can you develop compartment syndrome? So we have an increased pressure in a compartment, one compartment or all of them, doesn't matter. You have an increase in pressure. That decreases your ability to drain fluids from your veins. So you have a decrease in venous drainage. which builds up more pressure in those compartments because now you've got fluid retention. It compresses those vessels and nerves, so you decrease the oxygen delivery to those muscles. And then cellular hypoxia occurs. And remember what happens inside a cell if you don't have oxygen being delivered? You get acid being created from urea and lactic acid and hydrogen and ATP. Histamine is released. And remember, histamine is a potent vasodilator, but your veins can't dilate because they're being squeezed upon so much by the pressure. Histamine also causes leaky capillaries. So now you've got fluid leaking out of the capillaries into your compartments, which increases the pressure in your compartment, which decreases the venous drainage. And it's a big nasty cycle here. Now, I know some of you are really sharp and you're already telling me, Janet, there are 6 P's on that screen here. And I'm saying it's 5 P's of compartment syndrome. I got a little trick for you, okay? So yes, it's the 5 P's of compartment syndrome. That's because the 6th P is very, very, very rarely seen. It's very, very rarely cited in articles, okay? And it roughly starts from the top and moves down, okay? Roughly in this order. So we've got pain with passive stretching, paresthesia, pallor, pulselessness, paralysis, and poikilothermia, okay? Pain with passive stretching means I can move my arm all I want to, but if I have someone else move it for me, I'm being passive, I'm allowing somebody to stretch it for me, I have great pain, okay? Paresthesia is the pins and needles feeling that you get when you wake up after sleeping on your arm wrong. Pallor is just a fancy word for pale. Pulselessness, well, now we're getting into some serious stuff here. You've got compartment syndrome that is so bad it's causing pain. It's causing pins and needles feeling because you've impeded circulation. Your skin is pale because you're not getting blood flow. And now it's swelling so bad that you're not able to get blood flow to your veins, so you're having pulselessness. It leads to paralysis, and poikilothermia is a fancy word for taking on the temperature around it. So my arm right now, I'm in a 70-degree room. My arm is nice and warm. It's 98.6, let's say, okay? If I cut off my circulation, what little heat is in my arm is going to dissipate by second law of thermodynamics into the 70-degree room until my arm, because it comes the same temperature as the room, 70 degrees. That's poikilothermia. It's the last thing you're going to see before you lose your limb. Here you can see this patient has compartment syndrome because they are pale from here to here. They've got great pressure right here in their compartments. They've got a ruddy color in their feet here. They're probably pulseless or nearly pulseless. You see the skin is pale, but it's also shiny and taut. It's because there's so much pressure built up in those compartments, that skin's about to split. The pressure is so great. So of the 6 P's, this is Journal of Orthopedic Trauma. If you have a patient with compartment syndrome and you have one of the P's, any of the P's in your assessment, you are 25% correct in diagnosing compartment syndrome. If you find 2 P's, any 2, 68%. Finding 3 of the P's is 93% correct in diagnosing. 4 P's, any of these 4 P's right here, any of the 4 is a 98% correct diagnosis in diagnosing compartment syndrome. And you don't have a fancy CT scanner, you don't have a Doppler, you don't have ultrasound, you have nothing except your assessment skills. So how do we treat compartment syndrome? Not much we can do in the field, okay? Don't ice it, don't apply warm compresses, don't elevate it. Splint it in the position of comfort and transport. There's really nothing else we can do. We can certainly start an IV, certainly give them pain medicine, but this is the visceral ischemic type of pain that you can give huge amounts of narcotics to. It'll help, but it's not going to take their pain down to really a tolerable level. But you can certainly give them something to take the edge off. The cure for compartment syndrome is a fasciotomy. Now remember on that picture, you have all these compartments and all that little white in between each compartment. That white is fascia, and fascia is a very strong, mostly inelastic material. It's just not very stretchy at all. It's kind of silvery white in color, and it will stretch just a little bit, but not much. It's not meant to stretch. What's happening is there's an increase in that compartment, and that fascia is not stretching. So we've got to cut that fascia open so that pressure will be released. This is what it looks like here. Here's your fascia. And this is your skin, this is your fat, here's your fascia. As soon as you pop this open, a lot of times it will just split like you're ripping a sheet down the side. It has so much pressure, but looky here, as soon as that pressure is released, you have restoration of blood flow and venous drainage. So this is really good. Here is a person with circumferential burns. So this is actually an escharotomy. They had to cut through all the burned tissue to restore circulation. This patient had to have a fasciotomy, and now he's having to wait for this to granulate and kind of fill in over the course of time. Here's a really good one. Looky here. This has been packed, so this is actually gauze, but they had a fasciotomy. They released the pressure, the swelling went down, and now they're having to wound pack it every day. And ideally, over the course of weeks, you're needing to use less and less gauze because that tissue is filling in on itself. So with compartment syndrome, until that treatment's rendered, that patient can't do anything about preventing acids or toxins. It's happening. They've got the acids, they've got the toxins. It's within the compartment. The fasciotomy is the only thing that can be done. And it's not really something that we are encouraged to do in EMS. It depends on your medical director, the area of the country in which you live. If you are 3 hours away from the nearest first aid station, you may have to do this. If you have a hospital in every corner, you will never have the opportunity to do that because there will always be a doctor somewhere around the corner who can do this for you. With the fasciotomy comes that sudden release of pressure, which we talked about, and that surge of deoxygenated, potentially acidic blood gets towards that heart. So that's another reason why if you do a fasciotomy, you have to have IVs, you have to neutralize what acids there are, you have to give them oxygen. There are a lot of things that you really need to have in place before you have to do this. So I promised you I would close with this story. This story is not mine. This is told to me by the late, great Corey Pittman, a wonderful flight medic who lived in North Carolina. He passed away suddenly a few years ago. Actually, his anniversary of his death date is at the end of this month. Super nice guy. He told this story, and his widow gave me permission to continue this story. So we have a cattle farmer who was found pinned under the rear wheel of his tractor. His wife, he went out early afternoon to go do whatever. His wife noticed in the evening he didn't come home for supper. So she went out looking for him, and she found him pinned underneath the rear wheel of his tractor. Now he's alert and oriented. He's pinned under the rear wheel, okay? He's got injuries to his pelvis and both of his legs. She runs to the house and calls 911. And this is very rural North Carolina. So you've got neighbors coming, first responders, you've got the prayer chain started at church, you've got all this stuff going on, okay? First responders arrive and they radio ahead and say, okay, we've got ALS en route. How far out are you? And we will start getting this tractor ready to lift, okay? So the rescuers on scene are told by ALS, do not lift the tractor. Okay, all right, it's going to take us a while anyway, so they start getting their stuff ready. There's a big crowd out here in the middle of this field. The neighbors are there. They're trying to help this man, and he's like, seriously guys, thank you so much everybody for coming out. If you can just lift this thing, I'll just shimmy myself out from under and it'll be okay. Well, that's what was going on, and first responders like, I don't see why we can't just lift this tractor, right? And they can hear ALS coming. They can hear the sirens. They can tell they're just minutes away. Well, the family is there. Friends and neighbors are there, and they're like, seriously, lift the tractor. That's all we need. We don't need to wait for them to get here. So based on pressure from the family and the lack of knowledge on what's really happening here, Incident Command ordered the tractor to be lifted. Okay, ALS is right around the corner. As the tractor was being lifted from the patient, his condition deteriorated very rapidly, ALS arrives on scene less than a minute later to find the patient in full arrest, CPR in progress. Now, had the whole team known about this, it could have been avoided. And that's why we need teamwork, we need communication, we need education. We need everybody to understand this. You know, people are like, well, I'm a first responder, I don't do ALS, I don't do IVs, well, you don't have to, but you can understand why we do the things we do in ALS, and we can work together very easily. This is a team effort here. It's not me against you. We're all going to work together, okay? So points to remember, make sure and start that IV access and get fluid replacement as soon as possible, at least a couple of liters in, okay? Do not lift that weight until the treatment started. If you've got everything cribbed and you've got everything ready, that's great. Don't lift it yet. Coordinate, communicate. You've got BLS, ALS, extrication, construction crew, crane operators, tow truck operators, you've got the neighbors, you've got the farmers. Everybody can work together as long as we can trust each other and understand this very unique situation. It requires us to communicate with each other. Please do not just, you know, take initiative and say, I'm going to do it this way because this is the way I think it needs to be done. We need to make sure and communicate with each other. I'm going to go to chat now, okay? I wasn't able to monitor chat while I was doing this because I only have one screen right now. So I'm going to go to everybody. Sure, absolutely, thank you.
Great, thank you, Janet.
Yes.
Jared has mentioned how you explained this in such an easy to follow manner. Appreciates
Thank
that.
you.
So
Yes, thank
Justin's got a question. So when giving albuterol, would you put the 4 to 8 2.5 albuterols in a neb?
Yeah. Yep.
Okay.
Just yeah. And you may have to explain to your patient, I know you're not wheezing. I know you probably don't think you need this, but I need you to just take big lungfuls of this stuff because it's going to help you in the long run. If you give a little bit of explanation, the patient's like, oh, all right, you know, and they'll take those big lungfuls and get that absorbed in. Mm-hmm.
Okay. Barbara has a question. A year after a tibia fracture, this came up. Could have been caught earlier?
A year?
A year.
Wow. There has to be some other problems there because compartment syndromes, usually they set in within 72 hours. They can be a problem up to, you know, a week, but a year, I'm thinking there's some vascular problems there with drainage and things. That's just an educated guess on my part. But definitely you need to get that looked at. There's a drainage thing. It's a circulation problem that's going on that's keeping your compartments from draining properly.
Okay. Donald's question is, would rhabdo fall into the crushed syndrome category due to the amount of time on the floor?
If I understand his question, rhabdo can happen without crush syndrome, but crush syndrome can also cause rhabdo. So yes, definitely you can get rhabdo from laying on a hard surface, especially if the anatomy, your big muscles are laying there. So worst case scenario, you've got an elderly female who's a diabetic who fell on linoleum and she's laid there for a couple days before they had a well-being check on her. She's going to get rhabdo because she's not only not able to drink, she's not, you know, she's dehydrated. She's been laying there for a while. Even if she could roll around and get off that, she's always going to be laying on a part of anatomy that's going to break down. So she, you know, like I said, the side, the front, the back, you know, she can't move around, but she's laying on a hard surface. Best case scenario, you're a healthy 24-year-old who fell on a bunch of feather pillows. You know, you're not going to be as likely to do that because you're on a soft surface that takes up some of that pressure. Donald, tell me if I answered your question correctly, okay?
Okay, I'll watch for his response.
Okay, thank you.
Is there something that could affect a scuba diver, or is diving pressure not the same type of pressure that could cause this? Or is diving pressure not high enough?
Diving pressure isn't high enough. Diving pressure has to do with gas exchange and gas dissolving in your bloodstream. Crush syndrome is actual physical pressure on muscles. And there would be no way you could go deep enough to get that same pressure on your muscles without dying first. So it's two different types of pressure.
Okay.
Mhm.
Dave wants to know, did the farmer survive the rollover?
No.
No. Along with applying a tourniquet before lifting the object, would you go ahead and give calcium?
Yeah. Yeah, I would do everything I possibly could. If it's going to take them a while and I could even get down to the albuterol, I will do everything on my list possible before they could lift. You know, if they still aren't ready, okay, great. You know, you keep working on your thing. I'll go start another IV and I'll give some more fluids and I'll give some more calcium. Yeah, I'm going to do everything I possibly can before they need to lift that weight.
Okay. I had a question in chat. Let me go back.
Okay.
And find it. Oh, Donald said yes. Thank you.
Good. Thank you, Donald.
For those that are in BLS or going to be in BLS, what is the best way to help if you are first on scene of an accident where crush syndrome could develop and the ALS is en route?
Let ALS know. Tell them what your assessment is. I rely on my BLS partner to give me a good assessment. I never ever think, well, they're just BLS, they're going to miss it. No, BLS people can do an excellent assessment. So if you're BLS, you get out there, tell them, radio ahead and say, listen, this is what we've got. This is what I'm seeing. This is the size or the weight or whatever. Give them those factors. How long has the patient been reported to be under here? What is the object? What's the surface area? What's the anatomy that I see that's being crushed by this person? And by the way, the person's sample history is that they're a diabetic with renal failure. These things together, you're giving to your ALS crew, it's giving them the information they can plug in. Both of you are plugging in the same information. You're working together. That's telling them, okay, we've got a crush syndrome. We've got all these risk factors. They can start preparing on their way. Once they get there, if your teamwork works like this, you can get their IVs ready for them, at least the fluids, if that's within your protocol. You can do things for them. You can help hold an arm. You can put the IV tourniquet on there while they're doing other stuff. You can rip tape, all kinds of things you can do to help lessen the steps that they have to do. There have been times where I'm kind of stuck as an ALS person. I'm kind of stuck like, what am I missing? My BLS partner says, hey, what about this? I'm like, oh, depending on your relationship with your ALS people, you can prompt them saying, hey, did you think about some calcium? You're not stepping on their toes. You're helping them. You're working as a team. You're prompting them. And they're like, oh my gosh, calcium. What a great idea. Yes, thank you. You can't give calcium IV. They can, but you can work together with your critical thinking skills.
Yes, and Spencer just basically asked the same question.
Okay.
As a first responder, what is the most important steps we can take until medics arrive?
Yes, a good assessment and radio ahead with all the factors that you see.
Okay. Greg is asking, what is the timeline cutoff between rapid extrication and waiting for ALS intervention?
That's a variable. I mean, if your tractor's on fire, you got to get them out now. I don't want to put a time limit on something like that. Corey Pittman's farmer, obviously he had been there for a couple hours. He can be there for a couple more minutes. If you've got a gas leak, if you've got an explosion, if you've got a gunman, any of these things that cause you to have to cut your treatment short and get them out of there quickly is what you need to think about. You need to weigh your options. Like, I really want to get the fluids on there, but this thing's about ready to explode. So weigh your options that way. I don't want to put a time limit on anything because it's different every single time.
Okay. And Garrett is basically asking the same question. Is there a safe timeline where it could be safe to remove the equipment from the patient, as in if they had only been under the equipment for less than X amount of minutes, crush syndrome may not be a concern?
Right. And that's your factors. Remember, time, the weight of the object, how much surface area that object is covering, and then your patient's predisposing condition. So even if the worst case scenario, my little 80-year-old with a Ford Pinto on her legs, I would say a couple of minutes.
Okay.
That's me personally. I can't imagine something that quickly happening to her. Anything more than that, it's just so variable. You know, you can't put a time on it.
Okay, and how is the survivability rate compared to if the injury is not able to be tourniquet versus if it is?
You're only buying yourself a few minutes if you get a tourniquet on there. It's just a little bit of insurance. It's not a cure. It's not as important as fluids. So if you can't get a tourniquet on there, don't worry about it. Do the rest of the stuff, definitely. Tourniquet's just a little bit of insurance. That's all you're doing.
Okay.
Mhm.
Believe that's it. I apologize. I don't believe we missed anybody.
Okay.
If so, re-ask your question. If not here,
Absolutely.
we'll keep the question and answer open for a bit along with chat. Meanwhile, just stand by for closing remarks, and we're also going to be replaying the Get to Know Your Team video while we do that. But thank you so much, Janet.
Thank
Great
you for having me.
information. I have tons of comments on how much everyone appreciate it and so informative.
Good. Thank you for having me, guys.
Thank you. All right, stand by, everybody.
So thank you everybody for taking time out of your busy schedule to join us tonight. From all of us to all of you, happy EMS week, and thank you again for spending this time. Some clarification about the CEUs. We'll be emailing those out to you to the email address that you've provided. Also, a certificate will be included with your attendance gift that we'll be mailing out in the next week or so. So again, thank you, thank you, thank you, making this such a success from all of us here on the air care side of the clinical for air care to all of you. So thank you very much.
It's an honor for me to get to take care of somebody else's loved one, and this one will be a patient I'll never ever forget.
We picked up a patient that was very critical. She had gotten a diagnosis in Southern Illinois, where she's from, wanted a second opinion, came up to Rochester. In Rochester, she became very ill, got an even worse diagnosis, and was terminal and was given about 48 hours to live. The family wanted to do anything they could because her birthday was the next day and they wanted to get her home, and she wanted to be home where she could be surrounded by family and pass away peacefully.
And so the nursing staff and the family started trying to figure out any way to get her home at any means. Immediately, my partner and I said, we got to do this. Got up to the ICU and the family was just ecstatic. Nursing staff was so ecstatic to see us there. Well, it was 546 miles one way. And so it was a long trip.
I mean, the look on her face when we got her home, and they had a hospital bed in the living room set up for her. And I mean, just she looked at peace, relaxed and at peace.
We sang her happy birthday, and the family started crying, and hospice was crying. I think we were all kind of crying, and gave her hugs and wished her well, and we left. We found out later that the patient passed 4 days later, but just knowing that we gave her that little piece of peace and her last wishes to be home with her family, and we did that, and that's customer service. It's unforgettable.